All right, good morning. Good morning. This is class 3, the beginning of week 2. We are almost at the halfway point. You guys have done really, really well so far. Over the weekend, you had chapters 2 and 3 to read. These were big chapters. I know it took a long time. And then you had the tests in your spiral book on page 182 and 183. Did you guys take the tests and grade them? Everybody? Okay. When I call your name, just tell me either how many you missed or your score if you use the grading scale at the bottom of the page. If you did not get to it, just say pass, and I'll come back around to you next class to try to fill in that blank. Okay. Good morning. Try not to get too far behind on your reading. I know it's a lot, but try not to get too far behind on your reading because the class goes super fast and there's homework every single class. So if you start to get behind in the beginning, it becomes really hard to get caught up at the end. And remember, you have to return that yellow book to me on the last day. Brianna, Natalie, for both 2 and 3? Thank you. Katie? Cody? Thank you. Thania? Elena? Haley? August? Justin? Holly? 100. Thank you. William? 95 on both. Brandy? Thank you. Special? Harmony. Okay. These are for your the spiral book, page 182 and 183. Did you get 100 on both? If you look on page 201 in the back of the book, that's your answer key. So when you take the test, go ahead and grade it. And that way, when you come into class and I read your name, you can tell me what your scores were. And I'll get them from you next class. It's okay. All right. Any questions on what you missed? Anything you need me to explain to you or clarify? Everybody good on the homework? Remember, when it comes to fire safety, and this is what we were just talking about, in chapter 3, we talked about fire safety. Remember that patients and fires cannot be in the same place at the same time. So remove the patient. You probably will have a test question on fire safety on the written test. It's that important because during an emergency, we don't have time to go somewhere and look up what we're supposed to be doing. We don't have time to go ask a nurse, what do I do here? We have to be able to act. So emergencies always require action. Please remember that. Emergencies always require action. Everything else gets reported to the nurse. So if your patient is choking, you don't want to just go ask a nurse, what do I do? We need to act. We need to do the Heimlich or abdominal thrusts, they're calling them now. If the patient drops on the floor and they have no pulse, well, we're not going to stand there and look at each other. We're going to start CPR. Unless you were told specifically, do not do CPR. We start CPR. Let me talk to you just a little bit about DNRs because this concept gets really, really murky out there. DNRs are very, very easy. I don't know why people try to complicate them. They're very, very easy. A DNR is put into place when we know the patient is dying. We know what they're dying from, and we know that we can't fix that. That is the only time you get a DNR. That's it. That is the only time. Now, that patient might be dying of old age. We can't fix old age. If the patient is 96 years old and they're declining, right? We don't live forever. Everybody know that? We don't live forever, right? There is an expiration date on every body. Well, if the patient is 96 years old and they're slowly declining, then the physician might have a discussion with the family. Okay, listen, your mom is nearing the end of her life. We see the signs. We can't fix this. There is no magic. No matter what the herbal industry wants to tell you, there is no magic cure for aging. So what do you want us to do when mom's body fails? Now, we can do CPR, sure, but CPR is not a magic reset button. You don't spawn back with full life. You come back with the same body that you just died with. So in some cases, CPR doesn't make sense. If we have a patient who has end-stage cancer that we can't do anything about, bringing them back after they die isn't going to help them because we didn't fix the problem and they get to die again. Right? Make sense? But if our patient is has a sudden cardiac event and their heart stops, and that's something we can do something about, and we're able to do CPR and successfully revive them and get them to the hospital where we have treatments that can fix the problem, then CPR is a good idea, right? Does that make sense? So DNRs are super easy. If the patient is dying from something that we know about, it's expected, and we can't fix it, a DNR makes sense. So in a lot of cases, your DNR patients are going to be dying from an event that we expect. You've been told they have a DNR, don't intervene. These are the people that are in bed, not eating for like 2 weeks. We know it's happening. This is not a surprise. This is not somebody playing bingo. And all of a sudden, they're having an emergency. That emergency is something that probably should be treated. So let me give you an example, okay? Remember, DNRs only count for the death that's expected. So let me give you an example. Let's say that you have, this is an ethical dilemma, right? Let's say that you have a patient who has cancer. She's got about 6 months to live, roughly. Not much we can do about it, but we're going to help her live her best life for whatever time she has left. Well, she's in the dining room and she's doing fine. She's playing bingo. She's attending activities. You know, everything is good. She's just living her best life for whatever time she has left. She is in the dining room and she chokes on a piece of steak. Is that an expected death from the condition that we can't fix? No. So does the DNR count? No. Do you think this lady wants as many of those 6-month days as she can get? Right? She's got things to wrap up. So if you just stand there and go, well, she's got a DNR, I guess I'm not going to get involved. You've just robbed her of that little bit of time she had left. Get in there, do an abdominal thrust. She'll be happy. Okay? Make sense? So DNRs only matter when the patient is dying from the condition that we can't fix. Does that make sense? And those patients are usually in bed. Slow wind down. Good? So unless you have been specifically told, no CPR for this patient, intervene. Does that kind of help demystify DNRs a little bit? That concept gets really, really murky out there, and I don't know why. It's actually exceedingly simple. DNR does not mean do not treat. It just tells us what to do when the patient dies of the condition that we can't fix. Good? Good. So you won't have questions like that on the state exam because how do we know what to do with each patient? Care plan. So we go to the care plan for our instructions. You're not going to have to make those ethical decisions, but we do need to know what to do in an emergency. Okay. Does that make sense? Good. All right. Any other questions on chapters 2 or 3? Chapter 2 talked to you a little bit about ages and stages and cultures and, you know, how everybody's a little bit different, right? So I want to kind of talk about this a little bit, and I'm just going to touch on this just a little bit. The way you live your life is not the way other people live theirs. Respect their choices, even if you don't agree with them. You don't have to agree with somebody to respect their choices. Let me tell you the saddest situation I ever saw regarding this topic. There was a little old man, and I still think about him. This is like 35 years later. I still think about this guy. Little old man, he didn't speak much English at all. In fact, he had like 2 words. That was it. And his wife had died. His son and his daughter-in-law put him into the facility, and they came and visited. They were very, very active in his life, but he was still somewhat isolated because he really couldn't communicate effectively. But he was also Buddhist, and he had this little, on his bedside table, this little shrine. And the CNA that was caring for him apparently took exception to his religious choices. And he was already pretty withdrawn. Okay, his wife had died. He was going through some grieving. He was displaced. You know, he's in a facility. He can't communicate properly. He's already way behind the 8 ball. He's got some, you know, adjustment issues going on. Well, then his shrine got removed. Like I guess I think it was a Buddha, and I don't know the particulars, but I think it was a Buddha, was like desecrated. He stopped eating. He withdrew. He wouldn't get out of bed. He wouldn't communicate. He wouldn't participate. He just totally shut down. And he died about 2 weeks later. And as they were going through his belongings, packing them up, they found the Buddha. It was wrapped up in a pair of dirty boxer shorts shoved in the bottom of a closet. Now, of course, they're now going to talk to the staff, interview the staff, who did this and why. And it came out that the CNA that was caring for him on one of the day shifts found the Buddha to be creepy and removed it. Now, in my mind, her actions directly contributed to this man's death. If she had a problem with that Buddha, what could she have done rather than desecrating that shrine? Yeah, go to the nurse and say, hey, this thing is creeping me out. I can't go in there. Not my thing. And the nurse could have found a different assignment, or could have done a little cultural sensitivity training, which would probably be a better option. You don't have to agree with something in order to respect it. To me, that was absolutely heartbreaking because it was preventable. Remember I said that CNAs kill just as many people as surgeons every year? We just don't talk about it. It's not all slips and falls. A lot of this is how we treat the patient. So we have to be mindful that what we do matters. We're the ones that are going to have the most contact. So sensitivity is very important. Does that make sense? So chapter 2 touched on that. How do we know what to do with each patient? We follow the care plan. And it's not just the care plan, it's the whole care plan and nothing but the care plan. So don't add to it, don't take away from it, don't change it. It stands alone. While we're performing those tasks, we're going to be making observations. And then who do we report those observations to? The nurse. Very good. So now that we know what to do with the patient, we have to know how to do it. So every skill is going to start with the opening. Every opening starts with a knock. So when you go to the test and they give you your 3 care plans, that one sheet of paper that has all 3 care plans, and they hand it to you and they read it to you, and you are now ready to start, you're going to tell the evaluator, okay, I'm ready to start, right? You're going to declare. So you get to read that thing before it even counts on your time, okay? So you're going to read it and you're going to say, okay, I'm ready to start. And the minute you say that, your whole body is going to clench up because now you know you're being tested. And whatever was in your brain, gone, like gone. You are now blank. So I want you to remember this. every skill starts with an opening. Every opening starts with a knock. And if you could just remember that one statement, that's it, just that one statement, it will at least give you a starting point. And then once your mind should and your body should kind of roll into that opening. But you have to have a place to start. And that's what this will help you with. Okay. So once we knock, we're going to enter. Now, for the test, we don't have to wait for them to say, come in. You don't have to wait. Just knock and enter. But let me talk to you about a clinical setting for a second. If that door is closed, I want you to think just for a moment of all the things you do behind closed doors. All the things you do behind closed doors. And how would you feel if somebody that you don't know walked in on any of those things? Are you uncomfortable now? So in a clinical setting, if the door is closed, that means that person needs privacy for something. Fill in the blank. We don't want to interrupt that, whatever that is. So we're going to knock and we're going to wait. And if we don't hear anything, knock again, because it may be an emergency on the other side of that door. Who knows? If you still don't hear anything, crack the door open and announce yourself. Hey, it's Patty, the CNA. Is everything okay in here? If you still don't hear anything, then go in because there's probably an emergency. But we're going to give them lots of layers there to do whatever it is they need to do. But let me tell you the most horrible story that I was personally involved in regarding this. Horrible. When I was in nursing school, of course, nursing school students think they know everything by the time they get to their last semester, right? We are so close to being nurses and we are so full of ourselves. I was assigned to a women's unit, and there was a young woman in there, young mom. She had like 2 or 3 kids. She was very young. She was in her 20s, very young. And she was dying from cervical cancer. And there was nothing we could do. Nothing we could do. And this really kind of affected all of us because, I mean, it's very hard to lose a patient. It is absolutely heartbreaking to lose one that is young and has young children. Well, the door was closed. I was assigned to go in and give her some medication. And I went up to the door, kind of knocked a little bit, opened the door, and walked in. She was having her last few moments of intimacy with her husband on the other side of that door. And I interrupted that. I stole that from them. That has stayed with me throughout my entire life. That is unforgivable. I did not have the right to do that. It stole it from her, but it also stole that memory from him. Our actions matter, and knocking is way more important than you think it is. She died less than 24 hours later. How horrible is that? Knocking is important, guys. So we're going to greet the resident, and we want to be nice about this. Hello, how are you? Good morning, good afternoon. Just be nice. And then we're going to address them by name. This is a graded checkpoint. We cannot use honey, baby, sweetie, whatever terms of endearment you want. We're going to use their name. For the test, everybody is Mr. or Mrs. Jones. Yep. After we have addressed them by name, we have to introduce ourselves by name and title. Hi, I'm Patty, your CNA today. Then I'm going to tell them what I'm there to do. I'm here to brush your teeth, get you dressed, help you eat a snack, change your bed. What am I there to do? And then we're going to get permission. Now, this is specifically graded under preferences. If you notice, that line does not say obtain permission from the patient. So a lot of people get this wrong. If they just print off that checklist on Prometric's website, there's nothing on there that says you have to get permission. Nothing on that checklist. If you read it, that doesn't say get permission. But I'm going to tell you that permission is graded under preferences. So this is where the checklist will help you, but it's not the whole story. And that's really why you need this to be decoded by an RN. Okay. Does that make sense? Okay. All right. Then we're going to close the privacy curtain. Now, something about the privacy curtain. Not all skills require privacy. It's graded on some skills. It's not graded on others. And students get like really confused on this. Like, well, when am I supposed, is this a skill that requires privacy? We're going to make it super easy. Remember, I'm all about easy, simple, right? Simple. Close the privacy curtain for everything but feeding. Period. Period. Doesn't matter whether it's a graded checkpoint, your patient deserves privacy. They just do. If you're going to do hand and nail care, give them some privacy. If you're going to do exercises, give them some privacy. Just close the curtain for everything except feeding. And we're going to talk about that in week 3. I'll explain to you why we don't close it for feeding, but just close it for everything. Makes it simple. It's not graded on everything, but it's okay to provide privacy for everything. Okay. All right. Once you've touched that curtain, what are your hands covered with? Cooties. So what do you want to do about it? Wash your hands. Do you want to get your supplies before or after you wash your hands? After, because you need clean hands to get clean supplies. All right. Our cardinal rule here is don't touch the patient in any way until your hands are clean. Very good. We also learned glove rules. Now, glove rules are pretty easy. Do we wear gloves for everything? Okay. The reason we don't wear gloves for everything is because we stop paying attention to what we're touching with those gloves when we wear them for everything. I actually went and got a sub this weekend and thought about you. So how do we know when we're supposed to wear gloves? Well, if we're going to touch body fluids, anything ooey gooey that didn't come from us, personal skin, that skin normally covered by a bathing suit, or non-intact skin. Remember those wet body openings we talked about? If we're going to touch any of those 3, we need gloves. Now, if we decide that gloves are appropriate, that we're going to use them, what's the first thing those gloves should touch? The patient. That keeps those gloves clean for the patient. And then once you have touched the patient, you've got to pay attention to what you're touching in the environment so you're not spreading those cooties around. And then at the very end, when we take the gloves off, we have to make sure that we're removing them properly to prevent cross-contamination. All right. We also learned how to use a barrier. This provides a clean place to put our clean supplies. Remember that you need clean hands to get your clean supplies. So barrier is all about clean. We don't want the supplies to touch our uniforms, so be careful there. Go get the barrier first, put it on the table, and then get your supplies and put those on the barrier. That keeps you from holding supplies up against your uniform. We learned when to use a privacy blanket. Anytime the patient is uncovered or undressed, we're going to give them a privacy blanket. Remember that their temperature perception is different than ours. We're active, we're fully dressed, they're not. So we want to use this not only for privacy, but also to keep the patient warm. We're going to use it anytime the patient is uncovered or undressed, and we're going to put the blanket on over the sheet and pull the sheet down underneath so our patient is never completely exposed. When we're putting that blanket on, we do not want to snap or shake it because that aerosolizes pathogens. And then if we use a privacy blanket, we got to know when to take it away. You want to take it away after you remove your gloves if you've worn them, because you don't want to touch that sheet with dirty gloves that are going to go right up next to the patient's face. Good. Questions? All right. We also learned linen rules, or most of linen rules. Now, these are mainly repeats of what we've already learned. Linens can't touch your uniform. You have to have clean hands to get your linens, and we don't snap or shake linens. Now, the other two there, we're going to learn coming up shortly. But we did skip to the bottom and learn that unused items have to be discarded. You can't save them for later because anything outside of your vision, not considered clean. Good? Good? Okay. All right. Then we learned the closing. Now, the closing is done at the end of every single skill, doesn't matter what skill it is. And we want to make sure our patient is in a clean and safe environment. Clean and safe. So that means that the bed is in the low position. We've looked around. Is there anything that I can straighten or clean up? You want to ask them if they're comfortable. The test needs to hear that word. Are you comfortable? We're also going to address their preferences, right? This is emotional comfort. Do you want your head of the bed up? Do you want a magazine? Do you want your sheet on? However you want to address this. But we have to just go beyond the, okay, I'm done. Okay. You'd be surprised at how many people end a skill that way. They're just like, okay, I'm done. But the patient doesn't have their call light. The curtain hasn't been addressed. They don't have a sheet on. The environment is messy. They left all of their supplies on the table. They just turn around and say, okay, I'm done. No, you're not. Remember that the closing is going to take up about a quarter of the checkpoints for every skill we do. So don't skip it. Super important. Patient needs to be covered. I should never see knobby knees. Now, I've been saying that for a couple of years now, probably about 5 years. And I actually saw someone, good morning, I actually saw somebody in a local big box store that took my class several years ago. And she's actually now a nurse. And she was walking past me in the store, and she stopped and backed up with her shopping cart. She says, oh my gosh, Miss Patty. And I said, hey, how are you? How are things going? She told me where she was working and that she is now a nurse. She's an RN. And she says, I got to tell you that every time I walk into a patient's room and I see their knees, I immediately think of you. No knobby knees. So that will worm its way into your brain. And 5 years from now, you'll still be thinking about it. No knobby knees. But that sheet, even though it's not a whole lot of protection, there is a psychological element of vulnerability there. So we have to address that. All right, we're going to open that curtain. Skill is over. Don't need the curtain anymore. If the patient asks for the curtain to remain closed, that's fine. No problem. That's a preference. We'll leave the curtain closed. But who needs to know? The nurse, absolutely. And then we're going to give them their call light because they have to have a way of contacting us. Now, I told you I'm in a ton of groups, CNA groups online, right? This came up this weekend. Somebody posted in there, what do y'all do with these patients that won't get off the call light? And there were like over 100 responses. Girl, that call light is a privilege. Take that thing away. Hide the call light. Put it out of their reach. Over and over and over and over. If that patient did not need access to healthcare people around the clock, where would they be? Home. That's right. The fact that they're not home means that they need access to medical personnel around the clock. That call light is the one reason they're in this setting. That right there is what separates home from healthcare. Do you guys understand that? Because at home, you don't have any way to call for help if you have a problem. This is what makes healthcare healthcare. And if you decide on your own that a patient is abusing it, you have now set yourself way above that healthcare institution. You are making decisions for the patient beyond the doctor level. That call light is not a privilege. That call light is the whole reason they're there. If a patient is abusing the call light by hitting it every 5 minutes, that means that patient has an unmet need. And it's probably not the blanket they're asking for. It's probably the fact that they're scared, they're lonely, they're feeling abandoned. And those are all valid feelings. Those are all valid. Until you get your psychology degree, you do not have the right nor the responsibility to declare those feelings invalid. Do you guys understand that? If a patient is on a call light, they have an unmet psychological need. Now, it's not up to you to fix that, but it is up to you to report it so that we can get that patient the help that they need. Do you understand the difference? If you're hiding that call light and not telling the nurse about it, if the patient's on the call light nonstop and you take it upon yourself to get rid of the call light, then the nurse doesn't know there's a problem. Is that patient going to get the help they need? No, and these are the patients that usually go on a rampage. That doesn't turn out well for you. Does that make sense? So when we're talking about the closing, all of these steps are important. All of them are important. But this one will fail you. That's how important that is. Make sense? Okay. After we've done all of those things, we're going to go wash those cooties. I'm sorry, you close the curtain. Did I get that? The curtain? Okay. After we do all of that, we're going to go wash those cooties off of our hands because we're done with the patient. They're clean, they're safe, they're covered, they're comfortable, they have their call light, we've opened the curtain. All of those things are done. Go wash those cooties off. We're done with the patient. But if we have to chart, we want to do that with clean hands. This pen's going to go in your pocket. So you're going to wash your hands, chart, and then wash your hands again because this, where is it? This is an important checkpoint in skill with clean hands. Just like call light is a critical checkpoint, this one is also critical because if I take the cooties from this guy over to another patient, their immune system may not be beefy enough to fight that new invader off. Questions? You want to end the skill with a patient that feels cared for and cared about. We learned how to wash our hands. So we're going to turn the water on, whatever temperature you want, it's fine. Wet your hands, get some soap, and we're going to start rubbing together. We want to rub all surfaces, the backs of the wrists, in between the thumb and index finger, in between the thumb and, in between each finger, in between the thumb and index finger, the palm of the hand, the bottom of the hand by the pinky. How long do we have to rub for? 20 seconds minimum. If you only rub for 19 seconds, yes, they will fail you on that. They will. They will. 20 seconds minimum. There's no maximum there, but don't rub for 3 minutes. Those evaluators want to be at home in their pool drinking their margaritas, not watching you scrub your skin off. Okay. So 20 seconds minimum. Then we're going to clean each one of our nails by going down the nail with our thumb. We're going to circle our nails on the palm of our hand to get underneath, and then we're going to rinse. When we rinse, you do not want to touch the sink or the faucet. You want to keep your hands just in the water. After rinsing, you're going to tap to keep the water confined. Then we're going to dry our hands. However many paper towels you need, use them. Throw those away, though. We're going to get a clean, dry paper towel to turn that water off, because wet paper towels can rip and recontaminate your hands without you even being aware of it. Remember that faucet is the dirtiest thing in the bathroom. Those are the germs we really don't want to take back to our patient. We learn how to take a pulse. Now, the pulse, the care plan tells us radial pulse measured at the wrist. So should we pull out a stethoscope and get all fancy? No. We're going to use the radial pulse at the wrist. 2 fingers, fingertips, not flat part. We're going to put our thumb on the back to hold consistent pressure, and we're going to count what we feel under our fingers for 1 full minute, because that's what our care plan told us to do. Normal is between 60 and 100. During this skill, you're probably going to have to count with 2 evaluators. So you're going to look at your clock, pick a starting point, and say start. Count until that second hand gets all the way around and say stop. You're on one side of the patient, the evaluator's on the other side. You're going to get to write that number down so you don't have to remember it. And then the evaluators are going to switch places, and you're going to ask to count again. So you pick your starting point on the clock, you say start, and you count until the second hand goes all the way around. Then you're going to do your closing, wash your hands, and document. Wash your hands again. Good? For the test, you can be off by 4 beats in either direction. It's a huge margin of error, guys. Huge. We learn how to dress a resident with a weak arm. To do this, we're going to remember USA first. Undress strong arm first, dress weak arm first. To dress somebody, you want to gather your clothes before you undress them. You want to provide privacy. You want to support the extremities as you lift them from below with a flat palm. Don't overextend or force movement, and make sure the patient looks good at the end of the skill. The pants are in the right place. The toe seams are over the toes. The snaps or buttons are buttoned appropriately. They need to look good. You're going to put the call light in the stronger hand. That's a graded checkpoint. We learn how to do range of motion as well. Remember that CNAs do range of motion to retain function, not regain. So we don't do pain. We do not do pain. We're going to lift extremities from below with a flat palm. 2 points of support near the joints. We'll move slowly and smoothly and all the way back to start. Flexion extension is up, down. Abduction, adduction is side to side. Rotation is around. You're going to do however many repetitions are on the care plan. Any questions on what we've learned so far? These are the 11 principles that we have to learn in this class. Now, in week 1, we've gotten more than half of them covered. Today, we're going to learn 3 more. Am I going too fast for anyone? No? All right, so let's get into the first one. Go to page 116 in your book. If you look at page 116, let me stand up here. If you look down here, you can see all of the principles that are involved in this skill. And of course, they're always spelled out for us here. This is our short version of the skill. I have a video for it. And then this is our testing information. So somebody with your level of experience should be able to do this skill in 11 minutes or less. That's a lot of time to do this, a lot of time. This is going to be done on another testing student, so one of you guys might be the patient for this. That person will be positioned in a chair to start the skill. So your patient isn't in a bed for this skill. They're in a chair. And charting is not required. So if we go to the next page, this gives us our skill-specific instruction. At the top is our care plan. Our step-by-step instructions are located here. We've got some review questions, and then along the bottom are our supplies. Look at those supplies. If I ask you, hey, can you go do hand and nail care on room 354? I'm not going to say, and you need to take with you a barrier, a basin, soap, lotion, 2 washcloths, a towel, emery board, and orange stick. I'm not going to say that. I'm just going to tell you, go to hand and nail care. You got to know what to take in with you. So there's no way around this, guys. You have to learn your supplies. Otherwise, for the test, you're not going to get what you need to do the steps. You're not graded on supplies. There's no checkpoint that says got the right amount of supplies. But if you don't have the right supplies, you can't do the step. And that's what you are graded on. So flashcards, going to be your friend here, okay? If you have not made your own flashcards, you should. If you don't want to make your own flashcards, buy mine. I don't care which way you do it, but you need to do this because otherwise you're just not going to learn them. And that's going to be a problem on the state exam. Good? Good. Okay. All right. Remember, for you guys, they're $14.99 until graduation. All right, so let's look at this care plan. This care plan says provide hand and nail care to 1 hand. How many hands? What if the patient has 2? Still 1, yeah. Do we care why we're only doing 1? No. And for the test, they're not even going to tell you right or left. You get to pick. They don't care. Now, the reason they do this is because I don't know which ones of you have brand new kitty cats at home. I have no idea. And if you have a brand new kitty cat at home, your hands are going to be shredded because that's what little kitty cats do. They play with your hands and you end up with all these scratch marks, right? Well, if I'm picking you to be a patient for you to do hand and nail care and I look at your hands and I see one of them has a scratch, I'm going to tell you to do hand and nail care on the one that doesn't have the scratch, right? So for the test, this is wide open so the evaluators can modify it as they need to keep you safe, but also keep you from having to wear gloves. Because if there are no scratches and it's intact skin, we don't need gloves to do this. Good? Makes sense? Good? All right. It says the patient is sitting in a chair at the bedside and can move as directed. So is this patient paralyzed? No, this is you. This is you. So sitting in a chair at the bedside can move as directed. So, man, this is easy. We're going to do hand and nail care to 1 hand. That means we're going to put a hand in a basin and let it soak. We're going to take it out and wash it. Put it back into rinse. Take it out to dry. Clean under the nails. File the rough edges. Put some lotion on. And clean up. That's the whole skill. And how many hands we doing? 1. That's the whole skill. It's a mini mani, guys. That's it. It's a mini mani. Super easy. Super easy. Now, in order to do this, though, this is a washing skill. And we haven't learned any washing skills yet. There are a lot. We're going to get to that in a minute. But washing requires a principle, some steps that we're going to repeat for all washing skills. So right now we need to learn those steps. So if we look down here, we can see that we know skill rules. We follow the care plan. We're going to do our opening. We're going to use gloves if we need them. We'll evaluate if we need them. We're going to use a barrier for our table. We're going to use linen rules by not holding stuff up against our uniform, not snapping or shaking, and nothing goes on the floor. And we're going to do our closing. We already know those. We got check marks there. We've learned that. But what we don't have check marks on are these 2. So we have to learn these in order to be able to learn the skill. Everybody following me? Am I going too fast? Am I losing anybody? All right, so if you look up on the screen right now on page 112, we're going to learn washing rules. Now there's 5 washing skills. you have a pretty good chance of getting one of these 5 skills. Pretty good chance, but not like a huge chance. Because these fall under ADLs. And if you remember on class one, and I probably should put that slide in here. Class 1, ADL skills. There were a whole lot. It's the biggest category. There's a whole lot of ADL skills, like making an occupied bed, dressing the resident, hand and nail care, foot care, peri-care, partial bed bath, catheter care. Those are all ADL skills. So we've got a pretty good chance. We know we're getting 1 ADL skill, and out of those, half of them are washing skills. So we've got a pretty good chance of getting some sort of washing skill. So we got to learn these steps. Again, I've got a video for it. I'm not going to show you in class. I'll talk instead. All right. So if we go to page 113, we have our notes for what I'm about to say. So you don't have to take notes. They're there on page 113. But I want you to think about the way you bathe. You turn the shower on, you get in, and you get wet. Everybody with me? Okay. So after we get wet, we soap up something, a washcloth, a loofah, a scrubby, whatever you use. Could be your hand. I don't know. I don't care. But you somehow get soap on your body. Fair? Do you ever get out of the shower with soap on your body? Why? Okay, it would dry. It would become very itchy and sticky and icky, and nobody would do that. What are you, Miss Patty, crazy? Why would you even suggest that? It wouldn't enter our minds to get out of the shower with soap on our skin and shampoo in our hair because it's routine for us. But you actually had to learn that when you were 4 or 5 years old. Mama was teaching you in your nightly bath times how to bathe. And this is how we bathe. Whatever we wash, we rinse. Make sense? Good? And whatever we rinse, we dry. We have to dry off. Well, if we're bathing another person's body part, we still have to follow those steps. Whatever we wash, we rinse. Whatever we rinse, we dry. And believe it or not, you will forget one of them. You will. Testing has shown you will forget one of these. You'll probably remember to wash because that's why you're there, but you will forget to either rinse or dry because it's no longer your body. You don't have the consequences of it, and your brain is on other things. So I want you to get into the habit of saying this in your mind. Don't say it out loud, just sound a little weird. But in your mind, when you're washing anything, whatever I wash, I rinse. Whatever I rinse, I dry. And if you start doing that when you're practicing, you will not forget these steps when you're testing. Or even better, when it really counts. Good? Make sense? You will forget. You will. Because it's not your body that you're washing. But here's the problem. And these are all graded checkpoints, by the way. Washing, rinsing, and drying are all graded checkpoints. But here's the problem. We're not in a shower. Right? When you take a shower, you get wet, you soap up, you rinse off, and then you get out. We're not in a shower. The patient is sitting in a chair at an overbed table. I know that because my care plan just told me. This is where your patient is. So that means that we have to bring the water to them. If you put soap in that water, how are you going to rinse? Yeah, and that's like a whole nother step, right? That's like way more work than we want to do. Because we would have to take that basin over to the sink, dump it out, use a paper towel to turn that faucet on. Because remember, that faucet is dirty. Rinse it, fill it back up, and take it back to our patient. That's a whole lot of work. It's much better to keep that water clean for rinsing by not adding soap to it. Instead, we're going to put the soap on the washcloth. So we'll get our washcloth wet, wring it out, and add soap directly to the washcloth, not the basin. So our soapy washcloths can't go back into the basin. We use them and then we set them aside. Now, what should I have on my table? A barrier. So on my barrier, I should have an area for my clean things, but I should also have an area for my soiled things. Make sense? We're going to organize our workspace. All right, so we don't add soap to the water. That keeps it clean for rinsing. So if we're going to get water for bathing, we have to remember that that faucet is not clean. Our hands are. We washed our hands, we got our supplies, we got all set up. We did all the things that we needed to do. We took our basin to the sink, and now we're getting water. But that faucet is not clean. So what could I use between my clean hands and that faucet to turn it on so I don't get contaminated? A paper towel. So when we're getting water and our hands are clean, we need a paper towel to turn the faucet on. So do I need a paper towel to turn the faucet on when I'm washing my hands? Why? Yeah, because my hands are dirty and so is the faucet, and that's perfectly okay because I'm about to wash it. But if our hands are clean, we need a paper towel. Good? Make sense? All right. We're going to check that water, and we're going to check it with the inside of our wrist. It should feel warm, not hot, not cold, just warm. But we're not the only ones that need to check it. The patient does too. And this is a graded checkpoint. It's not just a graded checkpoint, it's a critical checkpoint. Patients have to check the water temperature. There's a couple of reasons for this. But the main one is this. Your perception of water temperature or any temperature and your patient's perception is going to be wildly different. And the reason is your age. That's what's going to play into this. As we age, the layers of our skin shrink. So when we're young, our layers are nice and plump. That plump layer provides separation. You don't actually feel the true temperature of the water because there's so many layers there. As we approach middle age, our layers start to shrink. As we get elderly, our layers are super thin, super thin. Have you ever seen an old person's hand? Looks like this, right? There's a big difference between those two hands. The difference is age, but it's also layers. Now, why do we care? Why does this even matter? It matters because those layers become a wetsuit. They're there to block external temperatures from affecting you, but also to keep internal temperature consistent. Have you ever heard the term burning calories? Everybody heard that term, burning calories? Well, that's a real thing because your body temperature is normally 98.6. It's actually a range, 97.6 to 99.6, but we just kind of shortcut it to 98.6, okay? That's our body temperature. Now, the thing about body temperature is that we have to stay in a really narrow range, like really narrow. And weather like today kind of messes our brains up because we think that, well, you know, the weather has this huge temperature range. Like yesterday, it was 81. This morning, it was 39. Like that's a huge temperature range, right? Well, humans don't do that. Humans are not the weather. Humans have to live in a very, very, very narrow temperature range. In fact, if you're under 95, it's hypothermia. Under 94, you're dead. Do you guys get that? Dead. 94 degrees. Our normal's 98. It's a 4-degree temperature difference between healthy and dead. Got it? Okay. So, how do we keep our body temperature 98.6 degrees when the weather outside is 39? Have you ever stopped to think about that? Here's a principle that you need to know. Room temperature always wins. Always. Always. If you take a pie out of the oven, that pie is about 300 degrees when you take it out of the oven. It's hot. Put your finger on it, it'll tell you it's hot. It'll burn you. Put it on the stove, leave it there for a couple of hours. When you come back after a couple hours, is that pie still 300 degrees? No, it has cooled down to room temperature. It'll never get colder than that. It gets to room temperature and it stays there. Now, pie goes well with ice cream. So let's take our ice cream out of the freezer. When you take the ice cream out of the freezer, it's probably about 5 degrees Fahrenheit. Put that ice cream on the counter and leave it for a couple of hours. What happens? It melts. It specifically warms up. And it warms up to room temperature. It never gets any hotter than that. So room temperature always wins. Doesn't matter what it is. This blanket is now room temperature. This pen is room temperature, but you are not. Everything in this room is room temperature, except for you. Put a whole bunch of bodies in a space, and the space warms up. Good? You guys understand this? Okay. How does that happen? I'm always a big fan of the how and the why. Well, in your body, specifically this part of your body, you burn calories. That generates heat. That's why we call it burning. It generates heat, and that heat is designed to keep you at 98.6 degrees alive. Alive. Now, this takes a lot of energy to create energy. So what we want to do is try to conserve as much of that body heat as possible. We don't want it radiating out. We want to keep it inside so we stay at that temperature and we don't have to work so hard. That's what that layer of fat is all about. Remember that layer of fat we just looked at? This one? That's what that layer of fat is for. It acts as a wetsuit. It keeps that heat that your body is generating inside. So what do you think happens if we don't have that layer of fat anymore? Yeah, we lose heat and then we feel cold. Have you ever seen an old person complain that they are cold? Or walked into grandma's house and you're like, Grandma, oh my gosh, it's 85 in here. And she's like, don't you touch that thermostat. It's fine. Well, it's because their bodies don't want to work so hard to generate heat to keep them at a temperature. And we always know room temperature wins. So if we make room temperature warmer, the body doesn't have to work as hard. Make sense? This is why your older people are usually cold, or why they all moved to Florida. Because they will tell you, I can't handle that cold anymore, and they mean it. This is real. This is physics. They mean it. They can't handle the cold anymore. But that wetsuit that we're wearing, that layer of fat, doesn't just hold body temperature in, it also keeps external temperature out from influencing us. And that's why when we lose that layer of fat, it's the temperatures of the environment are going to affect us, and we're going to feel it much more acutely than we did when we were younger. It's not just air temperature, though. It's also water temperature. So when you put your wrist in that water and you feel that water and it just feels fine to you, that patient is going to interpret that temperature completely different than you do. Because that layer of fat doesn't just keep our body temperature in, it keeps external temperatures from affecting us. When we lose that layer, they're going to feel temperatures a whole lot different. Does that make sense? So we don't just check the temperature ourselves and think that's good enough. We ask our patients to check that temperature as well. And this is a graded checkpoint. Any questions on this? It is a graded checkpoint. So let me tell you a story about this. I was at a nurse's station. I was in a facility that was kind of like, how do I explain this? Kind of like a wagon wheel, I guess. Nurse's station right in the middle, and there were hallways going off of the nurse's station. Well, I'm at the nurse's station charting, and I just had a patient fall, so we were doing neuro checks. It was a big thing, right? My attention is right here, and I'm hearing this screaming down the hallway. Screaming. I'm waiting for the CNAs to take care of it. Come let me know what's going on. And the screaming just continues. So I have to get up from what I'm doing, go down the hallway to figure out where the screaming is coming from. And it's actually coming from the shower room. So I open up the door to the shower room and steam comes billowing out at me and my glasses fog up and it takes a couple of seconds before I can even see what's happening. And the patient is sitting in a shower chair, kicking and hitting and fighting and just, going insane. And I'm like, what's going on here? You know, oh my gosh. So I run over and I turn the water off really quickly, throw a bath blanket over the patient so they're not cold. And I ask the CNA, what is happening? And she says, she won't let me wash her. And the patient is sobbing. And I'm like, what's wrong? What's going on here? And I'm trying to figure out from the patient what's happening. She says, it's hot. It's hot. There was steam coming out of the shower. The patient is saying it's too hot, and the CNA is completely ignoring the patient and shoving her under the stream. Help isn't help if it doesn't help. This was not helping the patient. Listen to your patients. Just because you think it's comfortable doesn't mean anything. You're not the one in the shower. It's that simple. So if you take that basin of water over to the patient and you say, is this okay? And she says, no, it's too cold. Don't argue. Just say, okay, let me warm it up. And keep warming it up until it's comfortable for the patient. We're there to help. I'm not sure why this concept is so hard. But you're going to work with CNAs who don't get this. They don't get it. They don't think they're there to help the patient. They think they're there to take over. They treat patients like they're idiots. Or worse, prisoners. We got to rewire our brains and make sure that we're helping, not hurting. That's why this checkpoint exists. And those evaluators have all had a situation. Remember I said those evaluators have worked as nurses in long-term care and also been instructors. They have the same level of experience that I do. And I'm telling you that every one of them has had that exact same situation happen. And they're thinking about that when they're grading on this checkpoint. And if you don't ask that patient, water temperature okay? They're going to think that you're going to be that CNA hurting the patient. Got it? The test is always about the patient, never about you. So whatever body part we're told to wash, we're going to hit all the points. Whatever we wash, we rinse. Whatever we rinse, we dry. Don't leave soap on the skin. This is what it looks like under a microscope. This is what soap on the skin makes it itchy. It dries the skin, could lead to skin openings because the skin is dried out and cracked. If you take too long here, guys, and the water gets cold, or if it gets soapy because you put soap in there or put soapy washcloths in there, address it. You can't rinse with soapy water. Cold water is uncomfortable. So pay attention to this. Hand and nail care, you should not have to change your water out. This is what you're going to put the hand in, take it out to wash, put it in to rinse, take it out to dry. That's it. That should take like a minute. That water should not have time to cool down. Partial bed bath, different, way longer skill. You got 19 minutes to do that skill. That water can cool down in 19 minutes for sure. So we want to move along here so our water doesn't get cold. If it does, address it. Good? All right. We're going to use a barrier. That way our dry surfaces remain dry. And this is actually a graded checkpoint. This step right here is on so many checklists. And I'm going to read the checkpoint to you so you can understand everything that is being graded with this one check mark. It says complete skill having rinsed, dried, and stored basin. That's all we have to do. You don't have to clean it. You don't have to disinfect it. Rinse it, dry it, store it. That's what the check mark says. Placing soiled linens in the hamper. Disposing of trash. Disposing of or storing emery board and orange stick, and leaving over bed table dry. If you miss one of those things, just one, if you miss one of those things, you do not get that check mark. There is no partial credit. So if you leave the orange stick and emery board out, you don't get that check mark. Doesn't matter that you did the rest of it. You don't get that check mark. This is on, other than the emery board and orange stick, this checkpoint is on almost every skill that requires supplies. You have to make sure that you put everything away, that you leave your environment clean. Boy, it sounds an awful lot like our closing. Good. All right, we're also going to put some lotion on. So we always warm up our lotion before we put it on because it's a graded checkpoint, and we wipe off any excess. So if I put lotion on and I leave, my skin is only going to absorb so much. So anything excess, if it stays on the surface of my skin and I go to pick something up, what's likely to happen? It can slip. And if this is a cup of hot coffee, I could get burned. Even if it's cold, that means I'm going to be wearing it, and that's no fun, right? So those are the steps of washing rolls. Now we're going to learn the steps of basin cleaning. I want to go back a slide, though, to this. Remember this checkpoint I just read to you? The very first part of it says complete skill having rinsed, dried, and stored basin. So what are we required to do? Rinse, dry, and store. Don't overcomplicate this. Basin cleaning is easy. We're going to rinse it, dry it, and store it. That's it. Rinse it, dry it, and store it. But there's a couple things I want to bring your attention to while we're rinsing, drying, and storing that might be important to you in the future. Not necessarily for the test, but in the future. And that's what we're going to talk about now. Basin cleaning is going to be a part of about 9 skills that we do. So roughly half of the skills that we do are going to require basin cleaning in some way. This is going to be on page 90, and our notes are on page 91. So when we're dumping a basin, no matter what the basin is, when we're dumping the basin, you kind of have to think to yourself, where does it normally go? If you're brushing your teeth, do you do that over the sink or the toilet? Sink. So where should you dump the basin for mouth care? Sink. If you go pee, where do you normally do that? The sink or the toilet? Toilet. So if we're working with urine, where should we dump it? Toilet. So put it where it normally goes. Please don't put urine in the sink, please. Okay. We're going to rinse our basin. Just rinse it. Dump the rinse water wherever you put the stuff. if we're rinsing out something that held urine, don't put the rinse water in the sink. Where should the rinse water go? In the toilet. So we dump it where it normally goes, and then we dump the rinse water wherever we put the stuff. Make sense? Easy. All right. Some videos online, if you go watch other videos, will tell you that everything above the waist goes in the sink, everything below the waist goes in the toilet. And that's not really accurate because foot care doesn't have to go in the toilet. It's bathing water. And wound drainage shouldn't go in the sink, no matter where it comes from. So that's not really a good principle to illustrate this. It's where would it normally go? It's a much better way of looking at it. Okay, good. All right, so we're going to rinse it. Remember our checkpoint said rinse, dried, and stored? Remember that? Doesn't say anything about soap, doesn't say anything about disinfecting, doesn't say anything about any, just rinse it, dry it, and store it. But there are going to be some situations where you're going to have to disinfect or clean a little more aggressively. These basins, everything in here, this is only used by this patient. When she gets admitted, she gets what's called an admission kit that has all of the basins that she's going to need. And they're actually going to get to go home with her if she wants. She can take this home and use it for a cleaning bucket or whatever she wants. But this is only used by her. We're not going to use it on you two and you and you. It doesn't get passed around the facility. It is just hers. So whatever cooties are in here are her cooties. Perfectly okay. It's kind of like you at home, right? You brush your teeth and you probably rinse out the big globs of toothpaste out of the sink when you're done. But you don't disinfect every single time the sink. You probably clean it before company comes, but you're not disinfecting it after every use. Well, basins are the same way. We don't have to disinfect them after every use. Sorry, I was in the wrong spot. Okay. But there are some times that we're going to have to disinfect, especially if we're working with a patient that's on chemotherapy or somebody that has a depressed immune system, maybe from HIV or something like that. So there are going to be some times where we do have to disinfect. Now, some facilities will use a spray disinfectant. Others will use disinfecting wipes. Doesn't really matter. This process is the same. Okay. If we have to disinfect, and it might just be as simple as soap and water too, but if we have to disinfect, we can't be holding on to that basin with our dirty gloves while we're disinfecting. It kind of defeats the purpose. So this is why most places will use a spray disinfectant, because that allows us to set the basin down and spray it without touching it. Now it's disinfected. Do you think we should touch it with our dirty gloves? So if we've disinfected, we need to use a paper towel to pick it up. Then we'll use a paper towel to dry the inside. Throw that away. We'll use a different paper towel to dry the outside, because remember, we disinfected the inside, not the outside. So different paper towel to dry the outside, throw that away. And then we're going to put it in the drawer. But the drawer, we don't want to touch that drawer with our dirty gloves. Drawer isn't like super clean, but it's not super dirty either, and we don't really want to make it that way. So we're going to use a paper towel to open the drawer to store the items. So this basin cleaning, dump it, rinse it, set it down, spray it. Paper towel to pick it up, paper towel to dry the inside, paper towel to dry the outside, and one more for the drawer. That's how we do basin cleaning. For the test, you can simply rinse it, dry it, store it. That's all they're grading on. You can get used to this process so that when you do have to disinfect it, you never have to change anything. You just have to add in the disinfectant, just add in the spray. But the process itself is always the same. Make sense? You're going to see this, like I said, 9 times. So don't get too upset if you don't remember it all right away. And remember, all they're really grading us on here is rinsing, drying, and storing. They don't really care about the rest for the test. I do, because someday in some setting, you're going to have to disinfect, and you're going to need to know how to do that properly without cross-contamination. So now we know everything that we need to know to learn this skill, all of the principles. We know our opening. We know to read the care plan. We know our opening. We know to evaluate if we need gloves. We know to use a barrier. We know linen rules. We know washing rules, basin cleaning, and the closing. So all of those principles now we know. What we have to learn now is the skill-specific steps. So let's look at those. This is the checklist for hand and nail care. All of those principles that we just learned are already checked off before we ever get to hand and nail care itself. 3/4 of our checklist has nothing to do with hand and nail care. You guys see that? These are just principles that got checked off. Not much to learn here. All right. So one of our checkpoints here is to soak the hand in a basin. It does not tell us how long to soak for. So as long as you put the hand in the basin, you got a check mark. Sure, you can stand there and stare at them for 2 minutes or 10 minutes. Where do those evaluators want to be? At home in their pool drinking their margaritas. They don't want to see you stare at somebody without talking to them. How awkward is this? Right? And that was only 15 seconds. So we're going to put our patient's hand in the water and then take it out. You don't have to soak for any amount of time here. Now, in a clinical setting, it depends on what I'm working with. If I've got somebody who I have been doing hand and nail care on twice a week for the last 6 years, and I know that I'm doing all of the tasks for them, there's really not much on their hands or under their nails, I'm not going to let them soak for very long. A minute or two is all I need. If I've got somebody that is a new admission, been living out in the homeless camp for the last 6 years and hasn't even seen a bar of soap, yeah, we're going to be soaking for a little bit longer because we got a whole lot more debris that we need to loosen up here. So it really kind of depends on what you're working with. Okay. Make sense? All right. So we're going to soak the hand. Then we're going to take it out of the hand to wash it. Now, anytime the patient's hand is put on a firm surface, we got to pad that surface. So I'm going to put a towel there to rest the hand on so that the hand isn't on that firm surface. We've got some padding. So the hand is going to be put on a towel, and I'm going to take my washcloth, wring it out really well, put soap on the washcloth. Wash the hand. After we've washed it, let me go back. After we've washed the hand, we have to rinse it. So I'm going to take that hand and put it back in the basin to rinse it. And that's perfectly okay. I can also just hover it over the basin and squeeze water on it. That's fine too. Now, again, depends on my patient. That homeless patient soaking for 5 or 10 minutes before I do his nails, you think that water's clean? So what do you think I should do before I put the hand back in there? Yeah, let's change it. Now, the lady, I've been doing her hand and nail care twice a week for 6 years, and I'm doing all of her tasks for her. That water is fine. I can use it for rinsing. It's kind of like you in the bathtub, right? Have you ever thought about sitting in a bathtub? Now, baths can be very relaxing, especially a couple candles, some bubbles, a few rose petals, right? Very relaxing. But it's every part of your body is in that water. Every part of your body is in that water. So you probably want to wash your face first. Make sense?
Well, I'm going to shower.
Yeah. And that's, Sure, absolutely. But still, every part of your body is still in that water, right? Baths are great. I love baths. However, we have to remember that when we soak something, that water could potentially become contaminated with whatever is on that body part. As long as the body part is relatively clean, it's perfectly okay. No problem. The dirtier the body part, the dirtier the water. So if you look at the water and it looks a little funky, change it out. Make sense? All right. So we've put it in to soak, took it out, put it on a towel to wash, put it back into rinse, and now we're going to take it back out and put it back on that towel to dry. And then we're just going to dry it. Easy, dry it. After it's been dried, we're going to clean under the nails. Now, we're going to use an orange stick, which is that wooden stick there, and we're going to use the slanted end of the orange stick, not the pointy end. And we're going to use it as a scoop. So we just slip it under the edge of the nails, circle it around, get any debris that's under the nails, wipe it off on our towel before moving to the next one. I don't want to take gunk from this nail and insert it under this one. So circle, wipe, insert, circle, wipe, insert, circle, wipe. So again, we're going to go by our care plan. And if we have any concerns, we would bring those to the nurse. If I've got a patient that has super, super, super short nails, I mean, down to the quick, and there's no white tip at all to get underneath, I'm not going to have you do nail care. I'll have you do hand care. So let me explain to you why we're doing nail care to begin with. It's actually not the reason that you think. Okay. How many guys have a pair of nail clippers at home? You clip your nails when they get long? And then you probably ignore them in between. Right? They grow, they grow, they grow, they grow. They get to a point and you think, oh, I got to clip my nails. You clip them down and then they grow, they grow, they grow, they grow. You get to a point, I got to clip my nails. You clip them down. If you filed them on a regular basis, you would never have to clip them. That's what hand and nail care is all about. It's preventative maintenance. It's keeping the nails at a manageable level and keeping them clean so that we never have to clip them, because nail clippers are advanced pieces of medical machinery that CNAs are not allowed to touch. You are not allowed to clip nails, and we don't need to if we're filing them on a regular basis, and usually once or twice a week, especially as we get older, because as we get older, the nails don't grow as quickly. Once or twice a week, perfectly okay to keep nails at a manageable level. Make sense? That's really why we're doing hand and nail care. Looking for any abnormalities, but mainly to keep those nails from getting too long. Make sure you wipe off that orange stick in between each nail. That is a graded checkpoint. Place the hand on a towel while we're doing this, not on a firm surface. That is a graded checkpoint. And then we're going to file. When we file, we want to file in one direction only, toward the center. So if you file your nails like I do, I know I've got one. If you file your nails like I do, right, this is just an emery board, and I've actually got a nail here that I need to file. So what I would do is I would take my emery board, I'd put it against a nail, and I'd go across it really fast, back and forth, right? Well, you actually can't do that with elderly nails. With elderly nails, we file in one direction toward the center, and then I come on this side and do the same thing. And that's because I'm getting old and I'm illustrating this. As we age, nails become very brittle, right? The collagen, the elastin, all the things that make your nails flexible isn't made the way it is in younger people. And we end up with these ridges. And a lot of times we end up with if you kind of looked at it really close, the nails would kind of look like this, okay? They're not nice and smooth like they are when you're young. Well, when you take that emery board and you go back and forth, those ridges are areas of weakness. And we're actually pulling and pushing the nail. And along that ridge of weakness, it's going to break. And you actually will split the nail right down the middle. And then it falls off. And it's horribly painful. Horribly painful. So we don't go back and forth really, really quickly. We go in one direction toward the center, this side, this way, and then you can just kind of get that point off. But don't go back and forth. Back and forth pushes and pulls the nail along that center. It's called longitudinal stress. We don't want to do that. Good? Good. All right. When you're moving the hand into the basin, out of the basin, to arrange the towel, whatever you're doing, if you're moving the hand, don't grab it from above. Remember to provide some support as you're moving it. And then we're going to apply lotion last. So I'm going to warm that lotion up in my hands. Put it, don't just squirt cold lotion on somebody, guys. That's just mean. Warm the lotion up in your hands, apply it, and then wipe off that lotion with the towel. And now we can simply clean up. We're going to clean our basin using basin cleaning. I'll take it to the sink, dump it, rinse it, set it down, pick it up with a paper towel, dry the inside, dry the outside, and then I'm going to put it in the drawer using a paper towel, and along the way, I'll grab that soap and that lotion. Now I've taken care of my basin, soap, and lotion. I've got a towel and some washcloths. Where do you think those need to go? Yeah, in the hamper, in the dirty linen. Should I throw them on the floor? Does anything go on the floor? Okay. So I'm going to take my dirty linens and get rid of those. Then I'm going to take my barrier, orange stick, and emery board and throw them away. Now I've got a clean environment and I can do my closing. Thank you very much, Ms. Jones. Is there anything else I can get for you while I'm here? Are you comfortable? Would you like a magazine before I go? Your environment's clean, bed's in a low position. Here's your call light. I'm going to open your curtain, go wash my hands. I'll read that care plan one more time just to make sure I got all of the steps. And then I'll tell the evaluator my skill is done. So let's take a look. Now that we know all of these steps, let's take a look at how we're going to use each one of these to fill in that checklist. So here's our checklist. We're going to read our care plan. Tells us to do one hand. So how many are we doing? Okay. We're going to do our opening and get these checked off. We're going to, oops, nope, not break. Not yet. We're going to evaluate if we need gloves. We might. I don't know who your patient's going to be. I have no idea. If they've got a sore or a skin opening of any kind, do you need gloves? Yeah. If they look like their hands have been homeless, do you need gloves? Sure. Absolutely. If their hands are pretty clean because they're there to test, you probably don't need gloves, but it's a judgment. Figure out if you need them. We're going to use a barrier on the table and get this check mark. We're going to utilize linen rules. Remember, nothing held against your uniform, nothing on the floor. If you don't use it, you lose it. We're going to use our washing rules and get all of these things checked off. Washing rules checks off a lot. We're going to use basin cleaning and get that checked off. We're going to do our skill-specific steps and get those checked off. And then we're going to do our closing and get those checked off. Now, if you look at that, not very many are that skill-specific. So if you just walk in and start with getting a basin of water, I want you to think about how much you've not gotten checked off. Good? All right. Remember to read your care plan. This is the care plan that's for this patient, nobody else. Nobody else. These guys get a different care plan because they have different needs. Like they may have chewed their fingernails off. Could be. Or maybe they're an amputee. Right? Different care plans for different patients. All right, so Jake's going to show you this video. Please look at the bottom of the screen for the actual checkpoint. As I'm doing the action, this is the checkpoint I'm getting marked off with the action that you're seeing.
Hello.
Good morning, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
I'm good. How are you?
Fantastic. I need to perform hand and nail care on one hand. Is that okay?
Yes.
Okay, I'm going to close your curtain, wash my hands, get my supplies, and I'll be right back. Now that I have clean hands, I can get my clean supplies. We're going to place a barrier on the table with the absorbent side facing up. This gives us a clean area for our clean supplies. And for this skill, I need a towel and 2 washcloths. We'll bring this over to the patient area. From our bedside cabinet, we'll get a basin, soap, and lotion, and an orange stick and emery board. We'll set these items on the overbed table. All right, Mr. Jones, I'm going to go get some water in the basin. I'm going to use a paper towel to turn the water on. Check the water temperature with the inside of my wrist. It should feel warm, not hot or cold, just warm. And we'll fill the basin about 1/4 of the way full. And then throw the paper towel away. Mr. Jones, would you like to check the water temperature? Is it comfortable?
Yes.
Can you submerge your left hand in the basin, please? Thank you. I'm going to put the washcloths in here. And we're going to rinse your hand using the first washcloth. And now I'm going to place your hand over here on the towel. I'm going to take the washcloth, wring it out really well, and apply soap. Now I'm going to wash all surfaces of the hand. The thumb, each finger, in between each finger, we'll clean the palm of the hand as well. And the webbing between the thumb and the index finger. I'll set that aside. Mr. Jones, we're going to put the hand back in the basin to rinse. And using the washcloth, we'll just squeeze water over the hand to rinse. I'm going to turn your hand over, and we'll rinse the palm as well. Okay. I'm going to lift your hand up and place it on this towel, and we'll dry your hand using the towel. We want to dry all surfaces. We'll go ahead and turn your hand over. Make sure that all surfaces are dry. And now we're going to clean your nails with our orange stick. We're going to use the beveled end of the orange stick. We're going to clean under each nail, circling it around and wiping it off on the towel in between each nail. So we'll clean under the nail and wipe. I'm going to repeat on all nails. And now that the nails are clean, we're going to use the emery board and file the rough edges. We always file in one direction toward the center. I'm going to repeat on all nails just to make sure that the nail edges are smooth and free of any rough edges that might accidentally harm the patient's skin. Once the nails have been filed, we'll get some lotion. And we're going to warm the lotion up in our hands before we apply it to the patient's skin. So I'll rub my hands together to warm that lotion, apply it to all surfaces, making sure to coat all of the skin surfaces. And then we'll take that towel and wipe off the excess lotion. That way, it's not a slipping hazard if there's any lotion left on the surface of the skin. Now I'm going to take your linens and place them in dirty linen. I'll be right back.
Okay.
And I'm going to go clean your basin. I'll be right back. I'll bring the basin of water to the sink, dispose of the water into the sink, and rinse the basin. We'll dispose of the rinse water into the sink as well. I'll set the basin down, disinfect it per facility policy, and then use a paper towel to pick it up. I'll dry the inside with a clean paper towel. Throw that paper towel away. Dry the outside with a clean paper towel and throw that paper towel away, and then get one for the drawer. On the way, we'll pick up the soap and the lotion with the paper towel, place them in the basin, and use the paper towel to open the drawer. We'll slide the basin, soap, and lotion in the drawer and close it with the paper towel. Now we can dispose of our disposables. So the emery board and the orange stick will go in the garbage along with the barrier. So we're just going to put these directly in the garbage can. Mr. Jones, are you comfortable?
Yes.
Is there anything else I can get for you?
No, thank you.
Would you like a magazine before I go?
No, thank you.
Your environment is clean. I'm just going to move this table out of your way. Here's your call light, Mr. Jones. If you need anything at all, please press the button and let us know. We'll be happy to come help. I'm going to go wash my hands. After washing my hands, I'll review the care plan, make any corrections, and tell the evaluator my skill is done. Guys. All right. Any questions on that? Yes. In a lot of clinical settings, that's what they're going to be using. And the spray soap may actually even say no rinse. Even if it says no rinse, we still rinse. Okay. But that's what's commonly used in clinical settings. Now, if you have pump soap, like what we use, that's perfectly okay too. You won't have bar soap in most settings. You might in home care, but most clinical settings. In the practice kits that we sell, we actually have spray soap. It comes as, there's little soap flakes, so it's not liquid. You have to add water, and then you shake it, and it becomes spray soap. Okay. Yeah. It's pretty common in clinical settings. It just helps with, it's not as heavy. It doesn't clump. Gel, it's hard to spread gel around. Spray soap tends to spread a little bit easier. It's lighter. All right. Any others? Any other questions? No? Okay. We're going to go ahead and take our break since it is that time. Let me see where I'm at here. Come back in 15 minutes and we will get into the next skill. All right, we're back. Am I unmuted, Jake? Okay. All right, any questions on what we've gone over so far? Any questions? No? All right. We're going to move on to another skill now. If you go to page 141, we have making an occupied bed. The notes are going to be on page 142. At the top of the page, you'll see your care plan, followed by step-by-step instructions, and your supplies are listed along the bottom. Here's the care plan that's on the top of that page. It says change the top sheet, bottom sheet, and pillowcase while the resident remains in bed. Resident can roll and move as directed, but cannot get out of bed. A bedspread, blanket, draw sheet, or underpad is not required for this skill. So we're just changing bottom sheet, top sheet, pillowcase. That's it. That's all we're doing. Our patient can't get out of bed. It doesn't say they can't move. Doesn't say they're immobile. It just says they can't get out of bed. Don't read into this what's not there. Anytime a patient can get out of bed or is out of bed, that's a great time to change the sheets. If you walk by a bed and there's no body in it, I want you to think to yourself, do those sheets need to be changed? Sometimes this is based on facility policy. They'll say, you know, sheets need to be changed every 3 days or something like that. But most of the time it's take a look, you know, if the patient's sweaty and the sheets are a little icky, they probably need to be changed. Think about the types of sheets you would want to lay in. The other thing that I like to think about too is that, you know, that feeling when you just change the sheets in your bed and you get in and everything is nice and crisp and clean and it just makes you feel good. Yeah, the more of that I can give to my patient, the better off they're going to be. So if it's only been a day or two and there's no body in the bed, then I probably will go ahead and change the sheets if I got a minute. Now, it takes me about 2 minutes to change a bed if nobody's in it. If somebody's in it, if there's a body in the bed, then according to this, I've got 14 minutes to get this done. So 2 minutes, 14 minutes. Time management says 2 minutes is much better. So if you walk by a bed, there's no body in it, just consider, can I change this? Make sense? But for this particular skill, there's a body in the bed, so we got to learn how to do this. Along the side there, you can see all the principles involved, the skill-specific steps. And we know a lot of what we need to know to do this skill already. But there's 2 things that we didn't get to with linen rules that are going to impact how we do this skill. So I want to start there. Remember with linen rules that linens can't touch your uniform. You have to have clean hands to get your linens. Don't snap or shake them, and anything that you get has to be used or discarded. We know those. But there's something else that we haven't covered, and that is clean rolls toward me, dirty rolls away. So clean rolls toward me, dirty rolls away. And when you use this principle, we're going to use it for everything that's under the patient, whether it's sheets or chucks or anything that's under the patient that we need to either put under them or take out from under them. We're going to remember this. Clean rolls toward me, dirty rolls away. When you do this, when you're looking at the bed specifically, if I roll the dirty toward the patient, that's rolling the top side of it. Grab a washcloth here to show you. Okay, so if I have a washcloth, right, this is my sheet. We're just going to make it a sheet. And I've got a patient on that sheet, right? So this is the part that touched the patient. Dirty rolls toward the patient. What I'm doing is rolling all of that dirty sheet on the inside, so I'm not actually touching it. I'm touching the bottom of the sheet, the underside of the sheet. Make sense? Now, when I put a clean sheet on, this is my clean sheet, I'm going to roll it toward me. So again, the underside of the sheet is what's facing up, not the part that's going to touch the patient, the underside of the sheet, the part that's going to touch the mattress. Now, if I put this under this, we're not getting direct contamination. Make sense? So clean rolls toward me, dirty rolls away. And you do that so that we don't get direct contamination. Now, I do want to point out that there's still a patient in the bed. So you're going to get contaminated. You know, when you change a bed with somebody in it, the second that somebody touches the sheets, it's no longer as clean as it was on the supply shelf. And that's okay. It's the patient's own cooties. It's okay. Make sense? Good? Good. So the reason I point that out is because as well as, okay, we have a bed with a patient and we've rolled the dirty sheet in, the clean sheet toward us. We've tucked the clean under the dirty. In addition to all of this, we also have a pillow on the bed. That pillow can stay there. That pillow's touching the dirty sheet. It can also touch the clean sheet. That's fine because the patient is also touching the clean sheet. Perfectly okay. What I don't want is that patient to be a very long time without a pillow. Comfort. Questions? So clean rolls toward me, dirty rolls away to change that sheet. Nothing touches the floor. We've already talked about that. Nothing touches the floor. Not clean, not dirty, nothing touches the floor. So we've now finished out linen rolls. Let's talk about the next principle, and that's going to be scoot and roll. When I say that nothing touches the floor, there is something that I do need to cover here, though. In a clinical setting, we don't keep laundry baskets in the patient's room. No hampers in the room. Nothing dirty stays in a patient's room. So where do we put it? If I can't put stuff on the floor and there's no hamper in the room, where do I put the sheets? So yeah, there's a couple different ways you can do this. Normally speaking, these hampers are in the hallway. So you could take the sheets out to the hallway, but that's a lot of walking. I don't have time for all that. So in most cases, I'm either going to put a chucks on the floor and put the dirty stuff on the chucks, perfectly okay, because that's a barrier. Or the preferred way is to go get a soiled linen bag. They're really light blue. They're actually stamped soiled linens. And take that into the room with you. Open it up. That's where the dirty linen goes. Now that bag, everybody's familiar with Tide Pods, right? Those are the original Tide Pods. The bag itself is water soluble and becomes the soap. So these sheets, when you put them in this bag, the whole bag goes into the washer. Nobody's taking the sheets out, shaking them out, looking for dentures or earrings or hearing aids or cell phones. That's up to us. When we're changing these beds, we've got to make sure there's nothing foreign in the sheets. So pay attention to that. But the whole bag goes into the laundry. Nobody's double checking. There's a special room on most units, especially acute care facilities. Most units are going to have a special room called soiled utility. And this is for everything dirty. If it's dirty, it goes here. So your dirty linens, your used food trays that dietary didn't pick up, anything dirty will go here. Anything clean cannot go into a soiled utility room. So if you went and got supplies, don't take those clean supplies into this room. Don't take dirty stuff into your clean supply room either, right? So clean stays clean, dirty stays dirty. Just kind of keep that principle in the back of your mind. We already know use it or lose it. So now let's move on to scoot and roll. Side rails are probably the most misunderstood concept in healthcare. Side rails do not keep people safe. They actually increase the likelihood of injury. And it's important that we understand that. But they're also a restraint. Side rails restrict a patient's ability to move about freely. I want you to think about you for a moment. When you go to bed at night, if you wake up at 1 o'clock in the morning and you're thirsty, you're probably going to get up and go to the kitchen and get whatever it is that you want. There's nobody standing there blocking you from getting out of bed saying, no, you're not allowed to get up. You're an adult. You do what you want. Just because we put an adult in a different setting doesn't mean that they don't have the right to do what they want. When you come along and you put the side rails up on a bed, you're effectively keeping that patient from doing what they want. And in criminal terms, this is called false imprisonment. Side rails are a restraint, no different than me tying you to these chairs. I don't have the right to do that. And it's not something I should do. It's unsafe. Make sense? So we have to understand that side rails aren't the safety device that we actually think they are. But there's actually something more nefarious about side rails that I'm going to get into in a minute. It's the equivalent of a crib with a child. When babies are babies, we put them in a crib because we don't want them to roll off or get hurt, right? It keeps them confined. But when that kid gets to be about a year old, does that crib work anymore? What happens? They climb out. Now, actually, what was designed to keep them safe is actually contributing to way more injuries because they're not falling from this level, they're falling from this level. And that's a big difference. Same thing with beds. Okay, side rails don't keep people safe. They have to go up and over them, which increases the risk of injury. So here's one of the biggest things about side rails that most people don't realize is that it's called entrapment. Patients can get their body parts, particularly their neck, trapped between the side rail and the bed, and it kills about 200 people a year. Restraints kill. They kill. And it's really sad because it doesn't have to be that way. Most people use side rails because they think they're keeping their patient safe, right? They don't want the patient up and walking because they're a fall risk. And you're going to hear that term a lot. This is a fall risk. This patient is a fall risk. Well, if we put a patient in bed and put their side rails up, what does that do to improve their balance, their coordination, or their strength? What does it do to improve any of those things? So it did not help this patient stay safe. It actually made them weaker, less coordinated, and more prone to falls. Side rails and forced immobility, when we keep our patients in bed because we don't want them to fall, will further increase the likelihood of a fall. It does not do what you think it's going to do. So because of that, side rails are used very, very rarely, and you will probably be told to put your patient in a chair, get them out of bed, walk them to the bathroom. And you might think as a CNA, this patient is too weak. I'm not walking into the bathroom. They could fall. But understand that the alternative is to make them even weaker. Your job is not to think or to reason. Your job is to do what the care plan tells you to. If you have a concern, who do you take that concern to? The nurse. Very good. Very good. Positioning rails are not side rails, though, and I want to make this distinction pretty clear. Positioning rails are half rails. They're just on the top part of the bed, like this. A positioning rail is there to help our patients reposition themselves in bed, turn over. It actually helps with their strength and mobility. It doesn't interfere with their ability to get their legs out of the bed, and that's the key component here. A full side rail, anything that keeps them from getting out of bed, is considered a restraint. A half rail is a positioning rail, and those are okay to use. But we don't need side rails. We just need to keep the patient in the middle of the bed. As long as the person is in the middle of the bed, we don't need a side rail to keep them there. Good? Make sense? So how do we keep a patient in the middle of the bed, especially if we have to turn them on their side? How do we do that? Well, it's just like you at home. If I put you in this bed, in the middle of the bed, on your back, and I asked you to roll over onto your side, you actually don't roll. You shift so that you're on your side, but you're still in the middle of the bed. You don't like being near the edge because your brain goes, hey, danger, I could fall. So you shift your butt. You actually kind of lift and shift so that you're in the middle of the bed after the turn. Well, we're going to do the same thing with our patients. If we're going to roll them on their side, we're not going to roll them so they're close to the edge. We're going to scoot them toward us first and then roll them so that after the roll, they're in the middle of the bed. When you do it in one step. You kind of lift up and shift. When we do it for somebody else, we have to do it in 2 steps, scoot and then roll. Good? This is not safe. And it is a graded checkpoint. If your patient is that close to the edge of the bed, they don't feel comfortable and they're likely to fall. So when you're working with a patient that is in bed, take a minute to look at them. Do they look safe? Because the evaluator's looking. So in order to make this happen, we're going to ask our patient to scoot toward us, and then we're going to roll them on their side so that after the roll, they're in the middle of the bed, but always facing away from us. Don't turn a patient towards you. There's 2 reasons. One of the reasons is weight distribution. When you turn somebody on their side, most of their weight is along their back. Gravity will always pull somebody back onto their back, not forward, back. So if your patient, if you turn a patient towards you, their back is way over here. And if gravity's trying to pull them in that direction, you're less likely to be able to stop that roll. You're going to have to reach too far, which means that there's a potential for injury there, both you and them. So we want to turn our patients away from us. And that way, if they start to roll back, we're right there. We just stop that roll from happening. Now, the other reason that you don't want to turn a patient towards you is simply impropriety. And there's no real easy way to say this, but you never want your patient eye level with your crotch. That, if your patient's ever been the victim of any sort of sexual assault, that can be a triggering event. It's also a vague threat. So we have to be careful not to put that kind of imagery into our, remember, our patients are vulnerable. They have to rely on you. They're likely to be abused. And your patients are well aware of that. They feel vulnerable when somebody else has to take care of them. So we never want our patients to be put in that position. So we always turn our patients away from us. Remember that side rails are not graded. There's no checkpoint that says use side rails for safety. The checkpoint is going to be this: keep resident positioned a safe distance from the edge of the bed at all times. That is your graded checkpoint, not side rails. So if you're relying on side rails to keep your patient safe and you turn them and they're right up against that side rail, they are not positioned away from the edge of the bed. You will not get this check mark. Patients have to be in the middle of the bed. Questions? All right, so, oh, that's not supposed to be. Jacob, could you make a note for me, please? Slide 150.
Okay.
Class 3. Skill specific. Thank you.
No problem.
I worked on slides all weekend, so there are some, I'm trying to make notes as I see so I can fix it. All right, so when we're talking about the bed itself, there's a couple different positions. There's head of the bed, goes up and down. There's foot of the bed, goes up and down. There's the entire bed, goes up and down. 3 different positions. For the exam, we don't use foot of the bed at all. We don't adjust it at all. It doesn't even exist in our domain. Head of the bed and entire bed do, though. Head of the bed, we're going to have to put up for certain skills like mouth care. Dressing a resident, it's easier if you put the head of the bed up. So there are some skills that we will adjust the head of the bed for during the skill. The entire bed, however, is up to you. If you're a tall individual and you have to bend, raising the entire bed up to a comfortable working height might be what you want to do because it makes it easier on you. But if you raise the entire bed up, what do you have to do at the end of the skill? Put it back down. You don't have to raise the bed, though, for the test. If you can bend, bend. It's 3 skills out of your entire life, bend. All right, so here's our skill-specific steps. Patients should never be on a bare mattress. So we are going to roll clean toward me, dirty toward the patient. We're going to tuck the clean under the dirty. So the patient's always on a sheet, even while we're changing it. Don't have your patient on a bare mattress. That's just, don't do that. So we're going to remove the old sheet and put the new sheet on at the same time, which means basically we're changing the bed at a half at a time. We'll change this side of the bed, roll the old sheet toward the patient, put the new sheet on and roll it toward me, tuck the new under the old, move to the other side of the bed, and we're going to repeat the process. Take the old off, smooth the new on. But the patient should always be in the middle of the bed during that process. So the way we're going to do that is clean rolls toward me, dirty rolls away. And this is a graded checkpoint, the way we do this. So remember I said we're going to scoot the patient toward us and then roll them away from us? Well, we want the patient on their side for this because they take up less of the bed. We want them to take up the smallest footprint possible. So we need them on their side. So I'm going to scoot them toward me, roll them on their side away from me, and that's our graded checkpoint, how we put the sheets on the bed with them in the middle. We're going to tighten the corners. Now, thankfully, we live in the 21st century. I love this because when I learned how to do this a million years ago, we didn't have fitted sheets in clinical setting. We had them at home, but we didn't use them in clinical setting. Everything was a flat sheet and you had to tie. And that was a pain. Tie and tuck, tie and tuck. We get fitted sheets for this now, which just makes sure the corner of the sheets are around the corner of the mattress. But man, they make this easy on you guys. Easy. But you do want to do this in a way that reduces wrinkles. The more wrinkles that are on the sheet, the more likely bed sores will form. Now, we're going to talk about bed sores and wrinkles and sheets and things like that in detail the next class. Not so much this one, but just remember we want to reduce wrinkles. We're going to put the top sheet on and we're going to make hospital corners. They don't have to be pretty. Get the corners of the sheet under the mattress. That's what they're grading you on. Remember, nothing touches the floor. If you don't put the corners of the sheets under the mattress, they're going to touch the floor. So this is all about just getting the corners under the mattress. Now, I'm going to show you how to make really good hospital corners because I'm a very old nurse and this is important to me. But for the test, they're not really grading you on how pretty your hospital corners look. Now, what they are grading you on is when you tuck those corners underneath the mattress, that's going to make the end of the bed, the sheet at the end of the bed, very tight. And that's going to pull your patient's toes down. So we want to loosen that sheet over the toes just to give them some wiggle room so it's not pushing the toes down. It's a graded checkpoint. We'll replace the pillowcase. We do this last because we want to limit the amount of time they're without the pillow. So pillowcase last. Don't hold the pillow under your chin like you do at home. That pillow has been snorted on, drooled on, spit on. I mean, don't put that right up next to you, and definitely not right up next to your face. Hold it out, take the old pillowcase off, scrunch the new pillowcase on like socks, put it on the pillow, and then smooth it out. That way it's not right up next to you. So you want to limit the amount of time without the pillow for comfort. Questions on this? So let's see how these principles are going to check off our checklist. So we're going to read our care plan. We're going to do our opening. We're going to evaluate if we need gloves. Now, I want to time out here for a second. One of you guys is going to be the body in the bed for this skill. You are fully clothed for the test. You will be fully clothed for the test. You are holding on to all of your own body fluids like a champ. So that means for the test, you being the patient, there's no need for gloves. Now, in a clinical setting, that is probably not going to be the case. Your patient is probably not going to be fully clothed. They're probably going to be leaking something from somewhere. And if I'm going to put my hands under somebody that is leaking something from somewhere, I'm definitely going to have some gloves on for that. So we're going to address the gloves as each situation independently, not as a blanket statement. Make sense? We're going to use a barrier so that we have a clean place for our supplies. We're going to use a privacy blanket because we are definitely uncovering our patient for this skill. And we know anytime the patient is uncovered or undressed, we need a privacy blanket. We're going to use our linen rules. Now, that means that we're not going to snap or shake our linens. Nothing goes on the floor. We don't hold them against our uniform. And clean rolls toward me, dirty rolls away. Scoot and roll. Patients should be where at all times? In the middle of the bed. And our occupied bed specific steps are going to be located there in black. Now, this has a lot of specific steps. So these are steps that aren't really repeated in any other skill. So these are kind of one-offs. And then we're going to do our closing. So all together, all of these things are going to make up our skill for this particular I'm sorry, I just lost my train of thought. All the steps are going to make up this particular skill. Now, one of the things that I want to explain to you about the test, it's a little bit different. For the test itself, just the test, you're actually going to have a laundry basket or a hamper at the end of the bed or within a step. It's right there. Remember, we don't have that in a clinical setting. So for the test, they're not going to make you go get a bag and put the linens in the bag or put a chucks on the floor or anything like that. You can actually use your table for the dirty linens as well. We have a barrier on the table, but we have clean linens there. So if you use your table for the linens, which you can, it's okay. You just have to make sure there's a clean separation between your dirty linens and your clean. Don't throw the dirty on top of the clean. Okay, but for the test, you've got the hamper right there. Just take this stuff off the bed, put it right in the hamper. It makes it super easy. It's close. Questions on this? Questions? All right, remember this care plan is for this patient. Different patients will have different care plans, but I'm going to show you the video on how to do this skill for the test exactly as the checklist requires. So that's what we're going to see now.
Good morning, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
I'm well. How are you?
Wonderful. I'd like to change your sheets. Is that okay?
Yes.
Let me close your curtain, wash my hands, get my supplies, and I'll be right back. After washing my hands, I'll get the supplies I need for this skill. So we're going to start with a barrier, putting it on the overbed table. This gives us a clean place to put our clean supplies. And then to make a bed, we're going to need a pillowcase, a top sheet, a bottom sheet, and a privacy blanket.
All right, we had some technical difficulties. Let me rewind a little bit.
We're going to start with the bottom sheet. So I'm going to place a privacy blanket over. This is going to
Sorry about that.
Right, everything is control front.
Good morning, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
I'm well. How are you?
Wonderful. I'd like to change your sheets. Is that okay?
Yes.
Let me close your curtain, wash my hands, get my supplies, and I'll be right back. After washing my hands, I'll get the supplies I need for this skill. So we're going to start with a barrier, putting it on the overbed table. This gives us a clean place to put our clean supplies. And then to make a bed, we're going to need a pillowcase, a top sheet, a bottom sheet, and a privacy blanket. We're going to start with the bottom sheet. So I'm going to place a privacy blanket over you. This is going to help keep you warm and provide some privacy as we do this skill. So I'll spread this out, being careful not to shake it or snap it, and lay it in place. I'm going to pull your top sheet all the way down, and we'll remove it from the bed. Wrapping it in a ball so that the trailing edges don't contaminate other surfaces. We're going to lay this on an unused part of the barrier on the table. Mr. Jones, can you scoot your whole body toward me? And then I'm going to ask you to roll to that side so you're in the middle of the bed. Thank you. We're going to remove the sheet from the top and the bottom of the bed, and we'll roll this toward the patient. Dirty always rolls toward the patient. And we're going to tuck this in under the patient's body, all along the length of their body. Now we'll take the clean sheet, unfold it, and spread it out on the mattress, being careful not to shake it or snap it or let it touch the floor. We'll secure the corners. And then we'll take the clean sheet and roll it toward us to minimize wrinkles. And then we're going to lift the bottom sheet and tuck this clean sheet underneath the bottom sheet, all along the length of the body. So we'll roll it toward us. And then tuck it underneath the soiled sheet. You want to minimize the wrinkles that are under the patient. All right, Mr. Jones, can you come back onto your back and scoot to the middle? You'll feel a big roll. Okay, I'm going to go to the other side of the bed now. Can you scoot toward me, please? And then roll on your side so you're facing that direction. Thank you. We're going to remove the bottom sheet from the bed, rolling it in a ball. And then we'll place this with our other soiled items on the overbed table. We'll stretch out the clean sheet. Attach the corners. Minimizing the wrinkles underneath the patient. Okay, Mr. Jones, can you come back onto your back and scoot to the middle, please? Okay. Now we'll put the top sheet on. We want to open this up and spread it out, being careful not to snap it or shake it. We'll lay this over the patient. Making sure that there's an equal amount of sheet on each side of the bed. And then we're going to tuck the sheet under the mattress. So we'll lift the mattress and pull the sheet so that it's flat under the mattress. We're going to come down about a foot from the end of the bed, pick it straight up. You'll see a triangle here, and tuck in the bottom. We're going to lift the mattress from below, tuck the sheet so that it's flat under the mattress. Come down about a foot from the end of the bed, pick the top flap straight up. You'll see a triangle. Tuck everything else in. We're going to loosen this over the toes. And now I can remove your privacy blanket. I'm going to roll this into a ball and place it with our other dirty items. Mr. Jones, can I take your pillow? I'll bring it right back. We'll remove the pillowcase by holding the pillow and sliding the pillowcase down. We're going to place this with our other soiled items and put the pillow on the table. We'll take the pillowcase, scrunch it all the way up to the corners, and the tag side of the pillow will go into the pillowcase. So we'll stand it up, slide the pillowcase over the pillow, hold the whole pillow and pillowcase, and slide the sides down. The opening of the pillowcase is going to face away from the door. Mr. Jones, can you lift your head up for me? Thank you very much. Are you comfortable?
Yes.
Let me dispose of my supplies, and I'll be right back.
Okay.
These are going to go into dirty linen. And then we'll dispose of our barrier. We'll place our table back and make sure our environment is clean. All right, Mr. Jones, is there anything else I can help you with?
No, thank you.
Are you comfortable?
Yes.
Would you like a magazine before I go?
No, thank you.
Okay, your call light is right here. If you need anything, just press that red button. We'll be happy to help you.
Thank you.
Bed is in the low position. Environment is clean. I'm going to go wash my hands. After washing my hands, I'll review the care plan, make any corrections, and tell the evaluator my skill is done.
All right, any questions on that? I like that one because it shows the close-ups pretty close of the bottom sheet. Clean rolls toward me, dirty rolls away. Any questions? Okay, we're going to move on to the last skill that we're going to cover today, which is a range of motion. We already know everything we need to know about range of motion. There's not much to learn here other than what the care plan wants us to do for this particular one. After this, we're going to jump into blood pressure. Now, blood pressure is a big, scary skill. It takes a lot to teach you blood pressure. However, it is not tested on the state exam. You are not going to have to demonstrate taking a blood pressure. You still need to know how to do it because CNAs need to know how, but it's not a tested skill. So take the pressure off of yourself, okay? So if you look at page 78, we see our overview of this particular skill. We already know to follow the care plan. We already know the opening. We know to evaluate if we need gloves. We know the closing. And we even know the steps of range of motion. We learned it last class. Remember, we support from below at the joints. We move slowly and smoothly all the way back to start. Flexion, extension is up, down. Abduction, adduction is side to side. And rotation is around. There's a video for this, and somebody with your level of experience should be able to do this within 4 minutes. It will be done on a real person in bed. Now, if you look at page 79 at the top of the page, you'll see the care plan. Below that are step-by-step instructions and review questions, and there are no supplies for this. But let's take a look at the care plan. It says, provide the following range of motion exercise to the resident's right elbow and right wrist. Flexion, extension. So if you remember, flexion, extension was up, down. So that means we're going to go up, down on the elbow, and we're going to go up, down on the wrist. Now we have to look at the care plan to figure out how many times we need to do that. It says provide 3 repetitions of each exercise. We also need to know, is this active or passive? Is the patient doing it and I'm just watching, or am I doing it? It says the resident is not able to help with the exercise. That means I'm doing it. So we're going to do our opening. We're going to bend the elbow up and down 3 times all the way to start, moving slowly and smoothly, monitoring for pain. We're going to move the wrist up and down 3 times, slowly and smoothly, all the way to start, monitoring for pain, and then do the closing. That's the whole skill. It's like 2 minutes. Super easy. So, since we know everything that we need to learn, nothing new to learn, and we've already reviewed our range of motion. I just forgot to go through the slides. We're going to support from below. We're going to move slowly and smoothly all the way to the start position. Flexion, extension is up, down. Abduction, adduction is not on this care plan. Rotation is not on this care plan. And we're going to monitor for pain. So if you look at the checklist here, we can see how all of these principles are going to be used to give us 100%. We're going to follow the care plan. We're going to do our opening. We're going to evaluate for gloves. We're going to do our skill-specific steps, and we're going to do our closing. And that gives us all of the checkpoints for this particular skill. Remember that this care plan is for this patient, nobody else. Jake will show us the video. It's literally 2 minutes. Jake's going to show us this video. And then we are going to get into blood pressure.
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
I'm well. How are you?
Fantastic. I need to do some exercises on your right elbow and wrist. Is that okay?
Yes.
Let me close your privacy curtain. I'm going to go wash my hands, get my supplies. I'll be right back. Okay, now that I've washed my hands, I'm going to have you extend your arm out, palm up. I'm going to do all the exercises. All you have to do is let me know if there's any pain or discomfort. I'm going to bend your wrist up towards your shoulder like you're making a muscle, and we'll do this 3 times. So all the way up and all the way back to start. Up and all the way back to start. Feel okay?
Yes.
One more. Up and all the way back to start, making sure the elbow is on the bed. Now we're going to move on to the wrist. We're going to move the hand up and down like you're revving a motorcycle, so light fist. You'll feel a little stretch. Let me know if there's any pain. We're going to go forward and back. Feel okay?
Yes.
Again, forward and back. Still good?
Yes.
One more. Forward and back. Okay?
Yes.
Very good. Is there anything else I can get for you while I'm here?
No, thank you.
Are you comfortable?
Yes, ma'am.
Would you like a magazine before I go?
No, thank you.
Here's the call light. If you need anything at all, press that red button. We'll be happy to come help.
All right.
Your environment is clean. Bed is in low position. We'll go ahead and open the curtain, and I'll go wash my hands. After washing my hands, I'll review the care plan, think about my skill, make any corrections, and then tell the evaluator my skill is done.
If I had to pick my skills for the state exam, that would be one of them. Super, super easy. All right, any questions on what we've gone over so far? Because everything that we've covered so far has to do with the test. We're going to switch over to non-tested now. I know you got to go. Any questions before we move on?
I'm getting ahead of things. It all makes sense in just a few moments.
Okay. So, oh, Jake, grab her real quick and give her the review sheets, please.
Oh, yes.
The 2. Thank you. Okay. So if you go to page 56, this is going to be our notes on blood pressure. And at the top of the page, you'll see it actually says non-tested skills. And that means that we're not going to have to demonstrate blood pressure for the state exam. We do need to know how to take a blood pressure, because if you're using an automated device, you know, one of those blood pressure machines, and it gives us an abnormal reading, something that's out of normal range, we can't be 100% sure that that's a problem with the patient. It could be a problem with the machine. The only way to figure out whether it's truly a problem with the patient is to take the patient's blood pressure manually, which is why you need to know how to do this. Good? Good. All right. So when we're talking about blood pressure, we've seen this graphic before. We saw this with pulse. And as a reminder, you have a heart. When that heart squeezes, it pushes out a wave of blood. That wave pushes the one in front of it. That wave pushes the one in front of it. This is how blood moves through your circulatory system. When a wave is created, when you're looking at that wave, there's more pressure in the artery as that wave is moving through. Think of a garden hose. When you turn on the water, the hose expands, more pressure. In between waves, when you turn the water off, less pressure. Those are the 2 numbers of blood pressure. The higher number is when a wave is moving through. The lower number is in between the waves. These 2 numbers actually have names. The higher number is systolic. That's the amount of pressure inside an artery when a wave is moving through. Diastolic is the bottom number, or the amount of pressure inside the artery in between waves or at rest. That should not be 0. There should always be some pressure inside. Okay, good, good. All right. So when we're doing this, if you were to look at an artery, you would actually see it bulge kind of like this, right? So we have this wave moving through and this relaxation, wave moving through and this relaxation. So when we're measuring this, the systolic is that top number or the part where the most pressure is. And the diastolic is the bottom number or the part where their least pressure is. This is how we document them. It's always the bigger number with a line and the smaller number, like a fraction. So you wouldn't say like a blood pressure of 120 and 70. You're not going to use that word and. When you use and, it actually means pulse and respirations. What we want to say is over. So 120 over 70. Does that make sense? Don't use the word and for blood pressure. All right, so what are our normal values here? Well, the top number or the part of, where the wave is moving through, our systolic, normal is between 100 and 119. Now, it used to be a little higher than that. They've recently adjusted it downward. So 100 to 119 is considered normal. Anything over 120 or over has to be reported to the nurse. Anything under 100 has to be reported to the nurse. So as long as it's between 100 and 119, it's considered normal for systolic. Diastolic, or the bottom number, normals are between 60 and 79. So anything under 60 would need to be reported. Anything 80 and above would need to be reported. As long as it's between 60 and 79, it's considered normal. Good? Good. All of that is in your book on page 57 in the first column on page 57. Your normal values. So how do we take this? How do we find? I mean, it's all well and good to say, when the wave moves through, that top number is a systolic. Well, what does that even really mean? How do we get that, right? So I'm going to actually explain to you the actions that we take, why we take them, and what's happening inside the body that gives us those numbers. But in order to understand that, we have to learn this, our dial. So simply how to take a blood pressure, if I were to try to describe it to a 5th grader, we're going to inflate the cuff to a certain level. We never go above a certain level. We're going to deflate the cuff very smoothly. And we're going to listen. The first thump you hear where that needle is, the number it's pointing to, that's your top number. That's your systolic. The last clear thump you hear where the needle is, the number it's pointing to, that's your diastolic. So we inflate, we deflate, we listen for the first, and we listen for the last. That's all we're doing with the blood pressure. Not counting, it's just, where did we hear the first one? Where did we hear the last clear one? Now, first means that nothing came before it. So when you inflate up to a certain level, and for us as CNAs, that's no more than 180. 160 to 180 is where we end. 160 to 180 is where we end. So we go up to somewhere around 180, and we start to deflate the cuff. So the needle starts to come down. It's going to be quiet. Because remember, we're listening for the first. And the first should show up somewhere between 100 and 120. And we're way up here at 180. So it's quiet. It's quiet. It's quiet. It's quiet. It's quiet. It's still quiet. Nothing happening. Nothing happening. Nothing happening. Nothing happening. Thump. The problem is that students tend to give up in that nothing happening. They'll say, I don't hear anything. Well, no, you're not supposed to. We're not at the first one yet. It's quiet. But we have to go up to 160 to 180 because not everybody is going to be in that normal range. In fact, about half of people are outside of that normal range. So we have to go up to somewhere around 160 to 180 to start, and we're just going to listen. And we're not going to think about normals. We're just listening for the first. Where is that first thump? So as you come down and you hear thump, pay attention. Where's that needle? That's your top number. You're going to hear more thumps. Thump, 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 thump. And the needle's still moving down. Thump, thump. We don't care how many. We don't care about those middle ones. They mean nothing to us. But the problem is that we're listening for the last clear thump, which means that nothing is going to come after that. It doesn't announce itself. It doesn't say, get ready, get set, here I come, ta-da. It doesn't do that. It just goes thump, 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 thump. Oh, where was that last thump? So you have to pay attention to them because any one of those could be your last thump. We won't know it's the last one until nobody else shows up. Make sense? Good. So this is actually very simple. We inflate the cuff, we deflate the cuff, we listen for the first, where's the needle? We listen for the last clear, where's the needle? That's a blood pressure. Turning your brain off is the hard part. Making yourself just listen and not give up, that's the hard part. Because remember, normal is between 100 and 119 on the top number. That means that you might not get any thumps until 100. And that's a whole lot of quiet time. And your brain is likely to give up on you. Don't. Just inflate, deflate, and listen. Sound good? Make sense? All right. So there's two pieces of equipment we need to learn how to use to take this measurement. So in front of you, you have a kit that looks like this. Unzip it and take out your stethoscope and your blood pressure cuff. Now, don't do anything with them until I give you more instructions. This is very, very important. You can actually knock your blood pressure cuff out of calibration if you inflate it, if it's not wrapped around anything. So just follow along. Don't go out ahead of me. Follow me, okay? I'm going to probably teach you something that it will be very surprising to you. All right, so the first thing we're going to talk about is our stethoscope. Now, our stethoscope has two ends. It has some earpieces, and then it has this end down here, which is called the head of the stethoscope. The head of the stethoscope often has two sides. A flat side is called a diaphragm. If you have something that looks curved, kind of like a cup, this is called a bell. Now, you could have two flat sides. You could have a diaphragm and a bell. Or you may simply just have one side flat and nothing over here. All of those are perfectly okay for CNAs. Different sides are going to do different things. Good so far? All right. Now, if you have two diaphragms, that means that we have to set this up to tell it which side we want to listen to. This is a microphone. That's all it is. It amplifies. It's a microphone. But we don't want a microphone what we're listening to and all of this air out here. Because this is going to pick up people jiggling their leg. It's a microphone. It'll pick up the zzz of the lights. It'll pick up everything. We don't want that. We just want it to pick up one side. So this has an on side and an off side. And we have to tell it which side are we listening through, the diaphragm or the bell. Now, these, if you look at it, this thing actually turns. The whole thing turns. Everybody good with that? All right. So if you're looking at your head assembly and you have two sides, you may see a little dot on one of your sides. See if you see a little dot below your diaphragm. Everybody see a dot? Not everybody has one, but if you do, you'll see a dot. That dot is your on side. So as CNAs taking a blood pressure, we want the biggest microphone we can find. So we are going to have this large diaphragm facing the same direction as that dot. If it doesn't, if it looks like this, your large diaphragm is not facing the same direction as the dot, you would simply hold down here and turn the whole thing around. Questions so far? Okay. Everybody that we passed a kit out to, they should already be set up because classes before you have set them up for you. If you have your own kit, please make sure that your diaphragm and your dot are facing the same direction. Now, let's go on to the ear tips. And this is the part that everybody gets wrong. I don't know why. Our human brains are wired weird for this. But these ear tips, this is what's going to transmit that sound. And it's a super small sound. Guys, we're listening to a wave of blood hitting the top of an artery, buried under muscle, fat, and tissue. This is not a big sound. We need this funneled directly at our eardrums to be able to pick it up. It's a super small sound. The problem is that your ear canals are not straight in. So some of you, like I said, if you're using a class kit, this has already been done for you. But some of you, if you have your own kits, your ear tips look like this. See how flat that is? See how straight those are? We don't want that. We actually need our ear tips to face slightly forward. And they move. These move. So if you hold, let's go. If you hold the chin strap thing, you can actually move these ear tips. And you want them slightly forward, not a lot forward, just slightly forward. Something like this. Now, when you put these in, there is a right and wrong way to put them in. When you put them in, the ear tips have to face away from you. So remember, it's always about the patient. These are going to face the patient. So if you hold these so they face away from you and you put them in your ears and then very gently tap your diaphragm, you should hear it clearly. Now take them out. Flip the whole thing around so it's facing you now. Put them in your ears and try that again. You probably can't hear it as well. Take them out. Turn them back around so they face the patient. Put them back in. And you can see that this is the correct way to funnel. Use the larger diaphragm, the large side. There you go. To funnel that sound to your eardrums. Okay? Good. So there is a right and a wrong way to put these in. Now, when you get home and you're practicing blood pressure, if you can't hear the thumps, look to see which direction your ear tips are facing. This is the number one error that keeps people from hearing blood pressures. So this just happened to me. In November, I went to my doctor and I know what my blood pressure runs. I have a medical condition that causes episodes of super high blood pressure. And when I say super high, I mean like super, super, super high. And this is a known condition. I've known I've had it. I take medication for it. It's fine. But I knew that I was in what we call a hypertensive crisis, and I went to the doctor, and the medical assistant took my blood pressure, and she put the blood pressure cuff on, put the stethoscope on, inflated it, and the needle went woo, and she says, "Oh, your blood pressure's fine. It's 110/70." I said, "No, it is not." She says, "Well, yes, it is. I just checked it." And I said, "Could you please check it again slowly? Because I just checked it before I came in, and that's why I'm here. And I know what my blood pressure is, and I know it is not 110/70. It has not been 110/70 in about 20 years." So she did. And she stopped, and she took it a third time and a fourth time. And she said, "I'll be right back." She went and got the doctor. The doctor came in, and the doctor checked it and looked at me and said, "Do you know that your blood pressure is super high?" I said, "Yes, that's why I'm here." Now, I wasn't trying to get anybody in trouble. That's not what this is about. But had I accepted the word of that medical assistant, my current situation would not have received medical attention. I needed the emergency medication that brings my blood pressure down quickly so I don't have a stroke. Had I not pushed back, had I not been my own advocate, I would not have gotten that medication. And I may not be sitting here with you today. What we do matters. And we don't fake it until we make it. Not with this. So be very, very careful with this. If you cannot get a blood pressure, it is perfectly okay to say, "I can't get this blood pressure," and let somebody more experienced take the lead. People's lives depend on it. My blood pressure in the doctor's office was 210/180, which is why she couldn't even get the blood pressure. Right. It's important that we understand what we do. Okay? Does that make sense? Now, thankfully, my blood pressure came down, and I haven't had a hypertensive crisis since. But I have a problem with one of my organs that causes these things. You can't tell that by looking at me. Don't prejudge your patients. Okay? We're simply going to inflate, deflate, and record what we hear. If you can't get it, find somebody else. Okay. Putting in your ear tips the wrong way is a very common error. Having the diaphragm turned in the wrong direction is another very common error. Both of these things will affect your ability to hear what you need to hear. And when you put this stethoscope in and out of your case, it's very likely to flip over. So take a look at your equipment before you start taking the blood pressure to make sure everything is set up properly. All right. Questions? Let's move on to the cuff. All right. So the blood pressure cuff, this is one size fits most, not one size fits all. It's one size fits most. So it actually has a handy measuring guide built right in. So if you open up your cuff, along the top edge, one of the short edges is probably a white stripe. That white stripe is actually your measuring guide. It'll let you know whether this cuff is going to work for your patient. Now, what we do in order to use this as a measuring guide is we put this underneath the arm about an inch above the elbow. So on me, I would take this white stripe and place it underneath my arm about an inch above my elbow. And when I do that, I want to wrap the two corners around. If I can't see either corner, this cuff is too small for me. If it wraps more than halfway around the arm, it's too big. So we take the white stripe about 1 inch above the elbow, wrap it around the bottom of the arm. So you're going to take the short edge. Yep. Nope. So not this part, not this direction. This direction. Hold it up. So hold the white stripe up. So no, see how it's at the bottom, that white stripe? Okay. So yep, that white stripe, this stripe is the one that we're looking for. So we take this and put it underneath the arm. Yep. And wrap it around. If you can't see either corner, it's too small. Good. That's how we gauge whether this will work for our patient. If you use a cuff that's the wrong size, it'll give you the wrong reading. It won't be accurate. Won't be accurate. Now, the other parts of your cuff, now this is important. Do not try to inflate this cuff until it's wrapped around something. That's why all of you have a can. We're going to be using this can in just a few minutes. Not now. Let me teach you the parts first. But please do not start inflating your cuff until we get to that point, because this gauge can be knocked out of calibration super easy, and then it's no good. It's worthless. Yep. Yep. Okay. So now let's learn how to read your dial. This dial has a bunch of numbers on it. All dials are pretty much the same. It has a whole bunch of numbers on it, and it has a whole bunch of lines on it as well. So if we look at this dial, you can see everything is marked in 20s. So we've got 20, 40, 60, 80, 100, and so on. The bigger lines in between are tens. So if I've got, this is 0, there's 10, 20, 30, 40, 50, 60, 70, 80, 90, 100. It's just that those odd ones aren't, the ones that start with odd numbers, they're not, the numbers aren't on here, but that's what they mean. Now, those little itty bitty teeny tiny lines, those are 2s. So if you look at this is our line for 140. It tells us it's marked. The next little tiny line is 142, 144, 146, 148, and then your line for 150. They're not 1s, they're 2s. That's important. As a CNA, we only report even numbers. You can't point to a line on this gauge for 139. There is no line for 139. There's a space, but that's not a line. Make sense? So keep your numbers to even numbers. So 20s are marked. 10s are big lines in between. 2s are the little teeny tiny lines. All right. So the way that we control all of this is through, kind of looks like a hand grenade. This is called the bulb and valve assembly. And you hold it in your hand like this, just like it is on the screen. You hold the bulb in the palm of your hand with the tube facing up. And when you're holding it, you need to be able to hold this metal dial, this metal valve thing, between your thumb and index finger. So when you're holding this, the bulb is in your hand, your palm, and you have control over this circle valve thing. Let me help you. Some assembly required.
This one goes here?
Yep.
No.
No, this is hers. We just have to set it up. go.
Okay, thanks.
You're welcome. No, some assembly required. All right. So when you're holding this, the biggest thing to remember is that the ball goes in your palm and you hold on to the silver dial. When you hold on to the silver dial, I want you to hold on to it like it means something. Don't let it go. Okay. Hold on to it. That's going to keep your needle moving at a nice, slow, controlled descent. If you open it a little and then let go of that dial, what ends up happening is as you let go of it, it moves and then that needle goes, woo, and now you can't hear anything. Okay. So this dial, opening and closing it is what's going to let air in and take air out of our cuff. And you are in control of this. This is how we control how quickly that needle moves, is through that little dial right there. So righty-tighty, lefty-loosey. So when we're holding this bulb in our hand, again, don't do this yet, okay? When we're holding this bulb in our hand with that little dial facing us, we turn it to the right to close it. That way we can put air into our cuff. Then we turn it to the left to open it. When you close it, don't tighten it because we're about to loosen it. So if you tighten it really, really hard, when you try to open it, you're going to have to give it a whole lot of oomph, and then the needle goes, woo, and you can't hear anything. Good? So we just close it till it closes. Then we pump until our needle goes up to somewhere between 160 and 180. And then we open that dial to the left just ever so slightly. Now, when I say ever so, I mean small Thumbelina motions. I mean so small you can't see it with a human eye. You're not going to turn it. You're just barely going to nudge it because this is super sensitive, super sensitive. Now, as a CNA, when we inflate, we only go up to 160, 180. That is our top point. That's it. Anything above 180 hurts. Do you know what effect pain has on blood pressure? Causes it to go up. So if we go up to 240 just on a routine blood pressure and this squeezes the arm and hurts, we're probably going to get a high blood pressure reading. Not because the patient has high blood pressure, but because we just inflicted pain. So routine, remember CNAs do normal? You guys remember that? Routine, 160 to 180 is all we need to do. If the patient has high blood pressure, is that your task? Who would do that? The nurse, that's right. We already have a method built in to handle this. Okay, so we close our dial, we pump until the needle gets up to somewhere around 160, 180, and then we stop pumping. Now, we're going to hold on to that little silver dial from this point on. Okay, we closed it, we pumped, our needle goes up. We're going to hold that dial then, that silver dial, and we're going to open it to the left ever so slightly. We're not going to let it go. Now, let me tell you what's happening inside the body while we're doing this. We put the cuff on, and blood is still coming into the arm. Yay, that's a good thing, okay? But not for long. Our needle's at 0, no pressure. Cuff is on the arm. As we start to inflate that cuff, and we bring our needle up to somewhere between 160 and 180, this is what's happening inside the arm. We are using that pressure, that air pressure in the cuff to squeeze in, and those muscles are actually going to squeeze that artery closed. Now I have no blood pumping in. Heart is still pumping. Better be. Okay. Heart's still pumping, but we've put up a roadblock here. Now what we're going to do is slowly open that road back up, very slowly. Now, Remember, the heart is still pumping. We have more waves that are joining, but they're all stacking up there, kind of like a toll plaza. They're all just stacked up, waiting to get through. They're waiting. As we open that valve ever so slightly, and that needle starts to come down, the waves are going to start at some point. At some point, there's going to be a big enough opening that those waves can push their way through. Now, when we get to that point and the first wave is able to make it through, we're actually going to hear, that's what we're going to hear, is that first thump. So we want to look at the dial when we hear that first thump, because that's the first wave that was able to make it through. And that is your top number. Now, this first thunk that we hear, it actually has a name. It's called a Karatkoff sound. You don't need to know that, but it is nice to throw that out there. It does have a name, but it's a clear thunk. You can hear it. It's nothing, 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 thunk. Okay? That's what we're listening for. What we want to do is pay attention to where that needle is when we hear that first thunk. Now, if you remember, each of these big lines are tens. So if I have a line here that's 100, big lines are tens. What are the little lines? Twos. I didn't make it all the way to a big line, so now I got to count my twos. So I've got 100, 102, 104, 106, 108. So this is where my needle was when I heard that first thunk. What is the top number of my blood pressure? 108. So this is our systolic number, or the top number of our blood pressure. Remember, our normals are between 100 and 119 for systolic. So is 108 normal? 100 to 119, somewhere in there. So 108 would be normal. So 108 falls in this range. Falls in that range. Not 180, if you might have transposed those. Okay, so we got our top number. That's awesome. Great. Well, if one wave was able to make it through, so will others. Okay, so thump, 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 thump. We're hearing all these waves as they go through. Thump, thump, thump. We're hearing them because the artery is big enough for those waves to get through. We don't care about those. So we heard one here and here and here and here and here and here. We don't care about those. Those make no difference in our life at all. What are we listening for? The last clear thump. So eventually that artery is going to be so open that the waves can't hit the top of the artery anymore. I mean, it's like me trying to hit the ceiling, right? It's too high. I can't hit it anymore. That's when our thumps stop. Our thumps, the Karatkoff sounds that we hear, is the wave hitting the top of the artery. But if you put the roof too far up, I can't hit it anymore. Therefore, no sound. Good? So what we're listening for is where those sounds stop, or the last clear thunk that we hear. So that, in this situation, is happening here. So this is my line for 60. What's one little tiny line above 60? 62. So my bottom number, or diastolic, where I heard the last clear thump, was 62. So my blood pressure is 108 over 62. 62 is that between 60 and 79. So 62 is normal. This blood pressure, 108 over 62, is normal. Do I have to report that to the nurse? No. If it wasn't normal, I would report it to the nurse. Good? Questions? We want to keep inflating that needle until it hits 0. So I heard my last one way up here. There's no more thunks. It's quiet, it's quiet, it's quiet, it's quiet. Keep going. Keep deflating all the way to 0 because that hurts. Your patient wants that cuff off. No more pressure. So keep deflating all the way to 0. And then we can remove our cuff and record our reading. So the first thunk that we heard, where the needle was, is our top number. The last thunk we heard, where the needle was, is our bottom number. And these two together, we call it 108/62, makes up our blood pressure. So here's your recap. You just inflate to 160 to 180. You deflate slowly and smoothly. Don't let that needle stop, and you are in control of that needle. Don't let the needle stop. Slowly and smoothly. We're listening for the first thunk, the last clear thunk. Go all the way to 0 before you take your cuff off. That's a blood pressure. It's not nearly as difficult as you think, but this requires eye, because we're watching the needle, ear, we're listening for thumbs, hand, we're controlling the descent, the inflate and deflate, and brain coordination all at once. Your hand has to control the bulb and valve assembly. Your ear has to listen for the thumps. Your eyes have to recognize where the needle is when the ear says, hey, I heard a thump. And your brain has to figure out what numbers all of those lines mean. So there's a lot going on here in a very short amount of time, and we don't ever want that needle to stop. So we've got to be able to do this while the needle is moving. So this takes a little bit of practice. In theory, it's not hard, but it does take some practice to refine. Okay. Now, if you look at page 57, I have a activity here. If you look at number 8, there's a little gauge right next to number 8. If you look at that, I know it's black and white, kind of hard to read, but if you look at that, can anybody tell me where that first thump is? What number? 130. What about the last thump? 90. So this blood pressure is 130/90. Is that normal? What would we do with that? Okay, look at the next picture there. What is that blood pressure? Okay, 108 over 62. So that's the same illustration as what I used on the screen with you. Is that normal? Okay. So you're starting to put the pieces together? All right. Your normal values are here on that page, the first paragraph of the first column. But I want to talk to you about these things right here. You want the patient's feet flat on the floor when you're taking their blood pressure, not crossed at the knees. Crossed at the ankles is okay. I really don't care about that. That really doesn't have an impact, but crossed at the knees does. It's all because of venous compression. So just to make it easy on us, so we don't have to remember which one's okay, which one's not, we just say everybody flat on the floor. Make sense? I want to ask which arm I can use. Now, if the patient has an arm we can't use, it's usually going to be located on the care plan. But it's still a good practice to ask our patients as well, because maybe they've got something going on they forgot to tell the nurse about. This is common if your patient is undergoing dialysis. If they have a shunt or a graft in one arm, we do not want to use that arm at all. If the patient's had a mastectomy or a breast removal, we don't want to use the arm on that side. If they've had a stroke and one arm was affected, we don't want that arm. If they have plates and screws and, they played Humpty Dumpty and we had to put them back together again, we don't want that arm. So there's a couple of reasons why we would not want to use a specific arm. Basically, I want the healthiest arm you got. But if they say, well, I don't care, whichever, either one is fine, we usually go with the left to be consistent. There is a little bit of a blood pressure difference between the left and the right normally. It all has to do with the size of the arteries. Left is a bigger artery. So we usually go with the left if we are able to use either arm. That just keeps our readings consistent. That way I know you've got left and you've got left and you've got left. So all the readings I'm getting, we know have a consistent basis to them. Make sense? Good. All right. Where you listen matters. Remember that we are listening to a wave of blood hitting the top of an artery buried under muscle, fat, and tissue. This is not a big sound. It's not. If I've got my microphone here, well, if I've got it right here, you'll hear me. If I've got my microphone down here, you're not going to hear me as well. It's just not going to pick up. Well, this is the same thing. So your artery is not in the place you think it is. When you hold your arm out, this thing that's sticking out, that is not an artery. That's a vein. Veins don't have thumps. That's not going to help me a bit. That's good for if you're taking blood, but not for our purposes. What we want is the artery that's buried way deeper. And the artery is not in the middle. The artery is actually on the inside. So if you look at your pinky and trace your pinky up at the fold of your elbow, so where the lines are, put 2 fingers there. Do we ever use our thumb? No. So 2 fingers and put your thumb on the back. You should feel thumps under your fingers on the inside. It's not in the middle. It's on the inside of your arm. Everybody find your thumbs? Now, a trick here is that you need to get your arm straight. If it's relaxed at all, you're not going to feel it. We need to get that artery popped way up high. So that elbow needs to be popped out. And you want to be at the lines, not up here. If you're up here, there's too much muscle in the way. We want to be at the lines on our elbow. So at the lines, inside aspect, 2 fingers, you should feel your thumbs. Anybody not feel your thumbs? It should feel like a pulse. Thump, 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 thump. Okay. So you're way too far over. It's on the inner aspect, like right in there. Put your thumb on the back.
Oh, right here.
Got it? Got it? Got it? Everybody good? All right. Find somebody else's. Grab an arm. Remember, if their arm is relaxed at all, it may be hard to feel. And you want to start light, but then go down a little deeper, a little deeper, a little deeper, a little deeper, because this is buried pretty deep. So you're way too far in the middle. So we're going to go right in here. Put your thumb on the back. Thumb on the back is important. Let's see.
Oh, your hands are full.
I know. I'm sorry.
just felt that. I was like, oh.
Right here, right under my fingers. Yeah. A little deeper.
Yeah. What does it mean if it's beating so bad?
That just means you have a high heart rate.
Oh, yeah.
Got it? Got it? The smaller you are often, the faster your heart beats. Little tiny birds, they just ba 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 ba. An elephant, boom, boom, boom. Right? So usually smaller, tinier things have a higher heart rate. Not always, but often. Babies, way higher heart rates than adults. Okay. Everybody got it? Good. So the 2 things that I want to bring to your attention here regarding finding a pulse is that the arm has to be straight. If your arm is relaxed even a little like this, you're not going to feel it because the artery is sagged way down in. We need to get that arm straight that pops that artery up where you can feel it. The second thing is it's not in the middle. It's more on the inside. So remember that where we listen matters. We're listening for a wave of blood. So if we have our stethoscope in the middle, are we listening over the artery? Probably not. And that means that we might not hear one of the thumps that we need to hear. We might hear some of them, but that doesn't mean we're hearing all of them. And where it starts and ends is important. That's our numbers. So where we listen matters. So take a minute when you're taking a blood pressure to kind of find that artery until you get your feet under you, until you know that's where the artery is. That way, you know where to put your stethoscope so you're getting the right thumps. Make sense? Good? All right. Use your stethoscope properly. Make sure the earpieces face the patient. Make sure your diaphragm hasn't turned around on you. Make sure everything is in good working order before you try to take a blood pressure. And don't forget to keep deflating. This is probably the number one mistake that students make because you get so excited. You're about to take each other's blood pressure in a minute, and you're going to get really super excited. You're going to inflate the cuff. You're going to deflate the cuff. And you're going to hear your thumps, and then you're going to stop. And that needle's hanging out somewhere around 60 or 70, so it's still pressure against the patient's arm. And you're going to take your stethoscope out, and you're going to, I think the first one was somewhere up here, and the next one was somewhere down here, and the patient's arm is going to reach out and slap you, okay? Because it wants that pressure taken off. So this doesn't end until your needle's at 0. Okay, don't get so excited about what you're hearing that you forget about the impact to the patient. So we're going to practice on cans rather than somebody else for a minute. So if you take your cuff and your can that Jake passed out, and you wrap your cuff around the can as snug as you can. You want to wrap it around so that the tubes hang down. And you want to hold it so that the gauge faces you. This extra flap that's hanging out there, just wrap it around the back. It should look like this. And you want to hold this in your non-dominant hand. So if you're right-handed, you should hold it in your left. If you're left-handed, you should hold it in your right. Jake, I'll need you to zoom in. Yep. Okay, can everybody see the TV screen?
I will fix it here.
Okay.
Better?
Yeah, that's good. Let's see if I can hold still. Okay, so I've got my bulb and valve assembly in my dominant hand, and let me just move this over. And the dial, the silver dial, is in between my thumb and index finger. So I'm going to turn it to the right just until it stops. Notice I'm not tightening it. I'm just going till it stops. Now I'm going to pump it up until that needle gets to somewhere between 160 and 180. And then I'm going to hold that dial, and I'm going to turn it to the left ever so slightly. Now my needle should start to descend. And it should look something like, I'm going too fast. It's hard to do on the screen here. Something like this. This is my rate. This is what I'm looking for. See that rate on the screen? Now, unfortunately, this needle is going to want to stop on me, so I have to open it a little more, and open it a little more, and open it a little more, and a little more, and a little more, and now a lot to get it to 0. So let me show you one more time. This time I'm going to look at this. Yeah.
Focus. It's having some trouble. Manually do so.
Thank you. All right, so I'm going to close this, inflate, and I'm going to slowly open this so it deflates at a nice, slow, steady, controlled rate.
all the way to 0. I got to open it a little more, 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 a little more. Give it a try. Couple times. Once, twice. Until you kind of got the hang of it. If the needle is not going up, that means that you have not closed your valve. Now, once you've tried it once or twice, you can take your cuff off of your can, and we're going to try it on real people. I want you to pair up. 4, 5, 6, 7, 8. Pair up. You'll take their blood pressure. They'll take yours. Don't get stuck on the first reading. Try it twice, no more than that. So you'll take theirs, they'll take yours. And then I want you to change partners. I want you to get 3 blood pressures on 3 different people in here today. So you got to change groups. Okay? Got it? Got it? You probably aren't going to get it the first time, and that's okay. That's okay. We want to put the cuff on so it's on the upper arm above the fold of the elbow. You should see those lines. If it's down under the line, you have to shove that stethoscope underneath, and now we're muffling that sound. You want that stethoscope out in the open. Go ahead and give it a try. If you're playing along at home, feel free to grab a blood pressure cuff and stethoscope and give this a try on anyone that you have hanging out at home. This isn't easy to do on yourself. You don't have enough hands, because if you're trying to use the hand that you're taking the blood pressure on to inflate your cuff, you're going to distort your reading. So try to do this on somebody else. Go ahead and give it a few tries. Yep, good. So, okay, hold on one second. I'm going to come help you. When we put this on, we want it to be snug. Now, this cuff is too big for her. She's teeny tiny. So, can I get you to put your palm up? Thank you. So, we want to wrap this around so it's snug. And so the dial is facing out. So, your stethoscope, you need your stethoscope. You're going to put your diaphragm here, and you really want to squish it down. Squish it in there. Okay, now we're going to close that to the right.
It's close.
Okay, all right, now pump it up. Yes.
Are you supposed to like hear a pulse before you start?
No, we shouldn't hear anything, because remember, it's first and last.
So
Way
you're
up
not
here,
gonna hear
so you're not going to hear
nothing
anything. Nope.
Mine was very high.
You're learning a new skill too, which everybody's going to be a little higher than it normally is. We're pumping more blood to our brain so we can learn.
Yeah.
Yep, hold it in place. Squish it in there. You're not going to hurt her.
You need the blood pressure?
Stethoscope.
Gotcha. Here we go.
Yes.
Not a problem. Sorry, didn't want to drop that.
You should not hear anything before you start. Should not hear anything before you start.
Trying to make sure I have it in the right spot.
There's no way to hear that, because right now the artery's wide open and the waves can't hit the top.
Okay.
So you won't hear anything.
But this looks like
That's correct. So we're going to find that artery. It's right there. So that's
Your
where
hands feel so good.
I'm so sorry. I know I'm cold.
Oh, it feels good.
Okay. Hold on one second. Let me come over here.
Wait, where's the thing at?
So let's take that off. Let's put this on here. Can you take your jacket off?
Yeah, I
That
think
would
it's
make
making
it-
a little bit harder.
Yeah.
Sorry to mess with you.
Okay. So we're going to put this on.
So I'm sorry. I was.
We want to find that artery, line our arrow up because our arrow is going to tell us where to put our stethoscope. We're going to put this on and secure it. And now your stethoscope goes right there. Yeah. And you want to squish it down. You're not going to hear anything yet. Are you right-handed?
Yeah.
Okay. Pick that up. Oh, we want to put it in our hand like this. Make sure it's closed. There you go. Clear as mud.
I was hearing all sorts of stuff.
You're going to hear your fingers creaking, the tubes rubbing together, other people talking. Not beeping. Not beeping. They're thumps. Here.
I don't hear nothing.
Okay. You're not going to hear anything yet.
I'm getting the first one. And then
Just
I'm not
listen.
getting the last one.
Just listen.
Sorry.
It's okay. My blood pressure's weird.
I'm
It's
sure
all
your
over-
blood pressure is fine.
It's all over the
It's
place.
me. Okay, so.
Some days it's higher than the others.
You're not hearing anything at all?
92.
I heard it on yours, like a little.
But mine was fat. You have like a slow beat.
I guess. I got no blood pumping. No.
Do you hear anything? You hear thumps
I
at
hear you
all?
moving. Yeah, I don't hear no thumps. He's a robot.
Okay.
Yeah.
All right. That's okay. We're gonna switch partners and try on somebody else because somebody else may have one that's easier to hear. So switch partners.
She's like, I'm a little difficult.
The last one is hard. The last one is hard. Yeah. Because it kind of fades out and you're not real sure when the last one is the last one. This is where practice is going to come in.
Right, I'm gonna let you try now and see. If you're any more successful.
Those of you that are joining us live, make sure that you download the worksheet for today. It's going to be located on flcnatraining.com. Under class 3, download the class worksheet. It looks like this. It looks like this. It's going to review the principles that we've learned today, as well as the blood pressure principles and the basin cleaning and washing rules review. So these make a great study packet if you fill them out with each class as we go through. Okay, so your stethoscope is in backwards.
Oh.
Okay. So I want you to put your stethoscope here.
See, I hear like my
I'll
arm.
just make
like
sure.
me moving on your skin.
Yeah.
Right?
Yeah.
Yeah.
Okay. Oops. So now just listen.
He heard mine, he said.
Yeah.
I know. Try pressing it down. I don't know. Let me try you.
It's good. I'm joking. This is hard.
Did you hear?
I swear I like hear my own.
I know.
It's not yours. It's his. You're hearing his.
I can't.
But these aren't, they're not big thumps, guys. These aren't like boom, boom, boom. Now, some people they are. But in most cases, they're just like little faint ticks, like tick, 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 tick.
Yeah, we got to flip it around. Hang on, hang on. Yeah, like
Patty, is there any way to get different tips for your things?
There are, but your ears will eventually get used to it.
Okay, 'cause I just think they're too big for my ears.
Yeah,
So I have to
that
go-
could be. And your kit probably, yeah, you have different
I
ear
do have
tips
lips.
in there.
Okay, all right,
Yep.
I'll try those.
So you want to really squish that down. You want as good of a seal here as you can get. Jake, did you call me?
You okay?
Okay.
Oh, yeah. Oops. My bad.
I know.
Why is it not going all the way up?
Because it's not closed. Got to go the other way. There we go.
Okay.
And then this we want here. It would be better if she were, if it were supported on the table, but hold this. Hold this.
So the first one was at 1:30, and then the other one was at 100.
Remember, you're learning a new skill. It probably is a little high, and we're
I have high blood pressure anyways, but I take
and we're learning. We're not perfect at this yet. So
Oh, I should have brought my chair.
okay, you want to work with her? You got about 12 minutes left, so keep practicing. Keep practicing. This is the best thing for you. Practice makes perfect.
Miss Patty, so
Yes.
the first one's gonna be the loudest one, right?
Maybe, not necessarily. Everybody's a little bit different.
Okay, because the first one I heard was loud.
That's good. That's good. Then that counts.
It was at 120.
Okay.
And then the last one was at 60.
Okay.
So
That's normal.
that's normal.
Yeah.
Well, 120 is one over, but
Not bad.
it's not bad. That's my normal blood. You ready? Okay. Do you want to partner up? Sure.
I heard it that time. It's really light though. It's like, that's what it is.
Yeah, there.
It's not gonna be like bump, bump, bump.
No, it's not a baseline. If you're expecting a baseline, that's not what it is. A lot of times it's just a very faint tick, 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 tick.
I don't know if that's dumps or it sounds like a growling stomach. You know, like you're hungry and it makes growling noises. That's what it sounds like.
I don't think that's.
I'm not sure.
Yeah, those aren't the thumps we're looking for.
Like it's like every little sound. Like
Yeah, this is where practice is going to come in to be able to distinguish between what you're trying to hear and all the other sounds. And of course, this room is very noisy right now. Keep that in mind. The room is very noisy right now. Got about 5 more minutes. And then I need to go over a few things with you. Turn it the other way. There you go. Let me see yours real quick. I think your diaphragm needs to be tightened. There you go. You're welcome.
That's probably right.
Do you hear the thumps?
Yeah.
Good. I'm not worried about you getting the numbers right now. It's all about hearing the thumps and figuring out that you really don't need 3 hands, although it feels like you do. You haven't heard any thumps at all?
Yeah, but it's like, I feel like it's like, I don't know if it's mine. I mean,
It's
what's
not
the
yours.
beginning, right?
Yeah, it's not yours. They're very faint.
I thought we had to bring our own, so I brought mine.
Oh, yeah. No, that's good. We used to require that every student buy their own, but that is a financial hardship for some. So now I have a classroom set that we allow you guys to practice with in here. But having your own is really kind of, it will help you because now you can practice outside of class. So that's best practice is to be able to have your own. Okay, did everyone hear one set of thumps? You didn't? Special? Okay, so stick around. Don't go anywhere because I'm going to work with you to make sure you can hear at least one when it's a little bit quieter. Okay? Okay. I want everybody to at least hear one so that you know what you're listening for outside of class. If you have your own set, you can practice on anybody that you can tackle. Good luck. But if you get an abnormal reading, it's very, very important that you not call 911. They are not there to double check your readings when you're learning. If you have a concern, send them to Walgreens, Walmart, Winn-Dixie, any of the stores that has an automated cuff and let the automated machine check it because those are calibrated.
I think in regards to that, like if I was taking my mother-in-law's blood pressure, if I get her blood pressure and then I do it on the machine because she has a blood pressure machine because she takes it every day.
Yep.
Per doctor's orders, and they should be pretty similar.
Pretty similar, yeah.
Okay.
Yours actually might be a little bit closer to accurate once you get some practice. Right now, you're not accurate.
Right, but
Uh,
it'll give me a good idea.
It'll give you a good idea. It takes roughly 45 blood pressures before you start to get accurate. You guys are not accurate today. Not at all. Not even close. And that's okay. You're not supposed to be when you're learning. It's okay. Today is all about hearing thumps. That's all you're trying to do today is hear thumps. Now you have to learn how to distinguish between the thumps you hear and all the other noises. The tubes rubbing together, your fingers creaking, the chairs, the AC, the lights, all of that. We have to learn how to distinguish what we're listening to from all of that artifact or external noise. And that takes practice. Best place to practice is in a quiet environment. This is not a quiet environment, but practice is really what's going to help you the most. Now, we do have the blood pressure cuffs and stethoscope kits in class. So if you come in early on Wednesday, a couple minutes early before we start class, ask Jake for a blood pressure cuff if you want to practice. He'll be happy to check one out for you. Okay? Sound good? If you stay after class, if you signed up for the week after class practice, the blood pressure cuffs are also available to you. But remember that this isn't tested on the state exam. Now, you do have to know normals because you will have a question on the state exam about vital signs, and you've got to be able to pick out normal and abnormal vital signs. So you do need to know that, but you won't have to demonstrate this. So breathe a sigh of relief. We're all happy about that. Okay. So before you run off really quickly, your homework tonight, you have chapter 4. Chapter 4 is intense. It's a lot of content. It's not presented in an easily digestible way, so I made this for you. This is a brand new, I just did this. You guys are the first class that gets it. On this side, these are all of the body parts or body systems, the different body parts that system is comprised of, and changes in aging per body system. This is what you need to know, especially those changes of aging. What's normal? On this side is what we can do about those, what we can do about it. Now, a couple of things that I want you to pay particular attention to on this because it's a brand new thing, so I want to point it out. All of these little icons here tells you what to do in an emergency. If your patient falls, don't leave them. If they look like they're going to fall, get them on the floor so they can't fall. People that are on the floor can't fall on the floor, right? So we're going to sit them down. If they can't breathe, sit them up. If they're eating and start to cough, stop feeding them. Okay? So this kind of tells you what to do in some emergency situations. This tells you what to do with all of those changes of aging. But I want to bring to your attention the very top. This is the one thing that you probably should get out of my class if you don't get anything else. Be nice. Be nice. Involve your patients in what you're doing. Don't go in and just start working on a patient without explaining to them what you're doing. If you're going to take somebody's clothes off, they better know what you've got in mind, why you're taking their clothes off. If they don't, they're going to fight back. If you want a cooperative patient, you have to be a cooperative caregiver. And that's what this is telling you. Okay? This really is a huge cheat sheet for the test. Huge cheat sheet for the test. So you guys are the first ones that got it, but this will help demystify chapter 4 for you. And you've also got, for those of you who are joining online, that's this. This is what I was just talking about. Those of you who, homework, sorry. Homework. You've got chapter, so I just went over homework. What do I need? Oh, CPR class. If you haven't signed up already, QR code is there. You've also got it on the first day sheet, but this, your review sheet. The review sheet for today's class on the back of it has stuff on blood pressure. So it'll help you kind of put into practice everything that we learned. I know it's a lot and I went over it fast. I know, but practice really is your key here. All right. I will see you guys on Wednesday. We won't go over blood pressure again, but you will have access if you want to practice it. From this point on, class actually gets easier. Okay. So congratulations. You survived the hardest part. See you on Wednesday. Until next time, happy caregiving. Bye.